Good evening, everyone. On behalf of Bankers Heart Institute, we would like to welcome all of you for this Cardiology Update 2020. And we have eminent speaker with us, Dr. Ashish Nabar, Dr. Darshan Jhala, and Dr. Bhavesh Vajifdar, sir. And after that, I am also there, and Dr. Sagar is also there. So we will have a short session on different parts of cardiology. And before starting on this occasion of Teachers' Day, I would like to wish all my teachers who are present here a happy Teachers' Day to all of you. So if everyone is okay, then we can start with Dr. Ashish Nabar sir's lecture first on a approach to wide QRS tachycardias.
Sure.
Okay, sir. Over to you, sir.
Shall I share the screen? Okay, here it comes. Okay, so we have 20 minutes to discuss something about wide QRS tachycardia, and the best way is to start the discussion from what do you define as a wide QRS tachycardia. And that's very clear that whenever the QRS width is above 120 milliseconds to a greater than 120 milliseconds, then it's a wide QRS tachycardia. But you should be careful to record the whole 12 lead ECG. So for example, if you look at this lead, you would have difficulty in calling it a wide QRS tachycardia. But the same tachycardia, when you look in the other leads, there's absolutely no discussion. So most important is to have a 12 lead ECG that will help you to confirm that it's a wide QRS tachycardia. Obviously, the reason to discuss this is that wide QRS tachycardia can be a VT almost 85% of the times. But then there are other few occasions when it can be a SVT, and to make a mistake of treating a VT like a SVT, say for example by pushing in verapamil, could be disastrous. Therefore, you should know whether your wide QRS tachycardia is a VT or a SVT. We'll come to why a SVT can also look wide QRS contrary to the general understanding. But there are a few other features that are important when you decipher a wide QRS tachycardia as to where is the particular VT, if your diagnosis is a VT, located, because that has implications in terms of ablation. And for example, if the wide QRS tachycardia is from the right ventricle, then the obvious diagnosis many times is arrhythmogenic right ventricular dysplasia. So you can say something about the etiology also. Now, this slide actually shows you that VT remains the most common cause of wide QRS tachycardia, but there are other reasons when a SVT can be broad, like for example, when it conducts with the aberrancy to the ventricle. So the rhythm originates in the atria, but it conducts with the aberrancy. At times it can conduct through an accessory pathway, and then it can be a wide QRS tachycardia. And many a times the delay is not in the conduction system, or it's not accessory that conducts to the ventricle, but there could be a scar in the ventricle or delay in the conduction to the ventricle, because of which the QRS is wide. And sometimes this slowness in conduction in the ventricle could be because of drug toxicity or electrolyte disorders. And then your supraventricular tachycardia could look like a wide QRS tachycardia. And the third group could be when the patient has a pacemaker. Obviously the QRS is wide, and if you have atrial tachycardia which is followed by a dual chamber pacemaker, then you could have it as a wide QRS tachycardia. So essentially, wide QRS tachycardia happens because it's a VT originating from the myocardium and the two ventricles are activated one after another, or the conduction to the ventricle is by the accessory pathway, or because of aberrancy, because of block in one of the bundle branch. So these are the reasons, but very, very important to understand that 80 to 85% of the times you will be dealing with a VT, and that's an important clinical statement to make. Now, how do you distinguish, or how do you read, how do you decipher a wide QRS tachycardia? Of course, the most important thing is AV dissociation. If at all you see a AV dissociation, you don't have to bother about other criteria, and it's clear-cut VT, because SVT would not happen with the AV dissociation, wherein the QRSs are more than the P waves. So therefore, AV dissociation is a hallmark of a VT. Then there are certain things that you must study in the QRS, and we'll talk about them in little more details. But it's the width of the QRS, the axis of the QRS, and the morphology, whether it's LBBB type or the RBBB type of wide QRS tachycardia. So for example, if you look at this ECG, you must know where to look is one thing of it. So for example, if you see a wide QRS tachycardia, and if you start searching for your P waves in this lead, which is already so wide and so tall, so deep, so you will never locate a small P wave in this lead, but you have to be smart enough to recognize that to locate the P wave, you have to look at a lead which has the smallest QRS, for example, this lead, lead 1. So then you can clearly see that this is a P wave, and then you can measure those P waves with your calipers, and you can see that they fall at a certain fixed interval, and that convinces you that there is in fact a AV dissociation. Once again, this is a very this is again a lead at the bottom, a rhythm strip. So it's important to look at the rhythm strips. And if you see, if you are convinced that this is a P wave, then you take your calipers and say, okay, this is the P wave. Now this interval, you can actually follow through the trace. When it's inside, you will not see. But once again, if you come here, you'll see that this is a P wave. Once again, you come here, you see. So this technique has to be a little bit mastered as to where to look for a P wave to find the AV dissociation, because that clinches the diagnosis for you. For example, one more trace which probably you look at these leads, you don't see any dissociation. But if you look at the lead V1, you can clearly see that the P waves are much less than the QRS and they come at fixed intervals. So very important to understand how to look for AV dissociation. And since undergraduate days, you have learned that if you see a narrow QRS beat amongst this broad QRS tachycardia, it could be either a capture beat or a fusion beat. And that tells you that it's a VT, because once again, this is a hallmark of AV dissociation, and locating a capture or a fusion beat again clinches the diagnosis for you. Now, this is sometimes understood in a wrong way when that if you see a VA dissociation, it cannot be a VT. That's not correct. If your ventricular tachycardia are slow, you have all the right to have a VA conduction. And then there could be VA conduction one-on-one. The P wave could be every time after the QRS, and that does not rule out a VT. So VA conduction does not rule out a VT. Let's move on. So wide QRS tachycardia, it's important to understand where you see them. Whenever you see them in the emergency, if you cannot apply your criteria well, you can go by the clinical situation that 85% of the times they are VT, and assume it as a VT, treat it as a VT, and then decipher, sit and see how the ECG in sinus rhythm looks, how the ECG in wide QRS tachycardia looks, and conclude what you are dealing with. Many times it is an emergency. It's important to realize that it is better treated as a VT. The next aspect that you look at is what is the morphology in the V1. Is it RPPB type? So is it this RSR dash, or is it LPPB type that is predominantly US complex in V1? Now, whenever you have a QRS width which is more than 140 millisecond in a RPPB type of wide QRS tachycardia, it's a VT. The same thing applied to LPPB, you need to have a little stricter criteria, because by itself LPPB is a wider QRS complex than RPPB. So if your the width of the QRS does help you. Mind you, all these signs are 60 to 65% perfect, and therefore in RPPB you may be more accurate by saying that if it's more than 140, I can bet on a VT. In LPPB you might be a little less accurate, but the width of a QRS is important. But a VT can also have a narrow QRS. Now, once again, it's important to remember this, that if a VT originates in the septum, then it activates both the ventricles simultaneously, and therefore it's narrow. So you have a septal infarct, and then you have a VT from here, it can be a narrow QRS. Whereas if the VT arises from close to the conduction system, once again, it can be a narrow QRS. So VT, a narrow QRS tachycardia can be a VT also. So remember that thing. And some of these things that we said already, via SVT can be a broad QRS because of the bundle branch block, because of antegrade conduction of the axillary pathway, because of drugs which slow the intramyocardial conduction. You can have a SVT with a wide QRS tachycardia. So width of the QRS does help you. But remember, if you see something like this, now this patient had a pre-existing LPPB, and here he has a sinus tachycardia. Sometimes it could be atrial tachycardia. So if the pattern is very typical of LPPB, it is the same pattern that was there in sinus rhythm, then you have to be careful that you might be dealing with a supraventricular tachycardia with a pre-existing bundle branch block. So it is good to look at the ECG in sinus rhythm. If it is the same bundle branch block pattern, then it is very likely that it's SVT. But for example, if somebody has in sinus rhythm LPPB type of a pattern, and during the wide QRS tachycardia, it's a right bundle branch block type of pattern, then it's definitely a VT. So same bundle branch block pattern, you can consider SVT, but if it's a different bundle branch block pattern, then it's a given thing. It's bound to be a VT. Let's so this is one example why your wide QRS tachycardia can be a SVT. So antidromic circus movement tachycardia. What's an antidromic circus movement tachycardia? The the tachycardia runs in a circuit which conducts atrium to ventricle by the axillary pathway and ventricle to atrium by AV node. So that is an antidromic axillary pathway. So because the ventricle activates by axillary pathway, if you look at this wide QRS tachycardia carefully, you would see that the polarity of the QRS is going to be similar to the polarity of the delta wave in sinus rhythm. So you have a delta wave which is negative in V1, and so there is a delta wave in sinus rhythm. That one thing tells you that you are probably dealing with the SVT. But this delta wave pattern, this onset of the QRS would fall into the location of a particular axillary pathway. So that is very typical of an antidromic circus movement tachycardia. Mind you, in general, the antidromic circus movement tachycardias are much less common than the orthodromic circus movement tachycardias. And this is an example of drugs. So nowadays we have this flecainide available to us. We use it for atrial fibrillation. It is very likely that when somebody was in sinus rhythm, he had a narrow QRS. He's on flecainide because he gets AF episodes. One day he gets an AF episode. That high dose of flecainide causes slowing in the myocardium, and the atrial fibrillation or atrial flutter can run to the ventricle with a wide QRS. So this is a peculiar example of where myocardial conduction slowing by drugs can cause a wide QRS. Now let me stress on the axis of the QRS. So what is important is to, and this is a good sign. So let me stress on you that take this message home, that if your QRS axis is disparate to the bundle branch block. So if you have a left bundle branch kind of a wide QRS tachycardia with a right axis, or if you have a right bundle branch block QRS tachycardia with a left axis, so you have a axis which is disparate to the type of bundle branch block, it's a VT. It's a VT. So there are some examples here of a left bundle branch block tachycardia with a left axis, which is a VT, and you have an example here of a right bundle branch block tachycardia with a right axis. So axis which is commensurate with the bundle branch block pattern may not help you to decide whether it's a VT or SVT, but if you get a discordant axis, then it helps you immediately. It's very likely to be a VT. So it's important to remember. Again, in a Holter, sometimes it is good to see. For example, if you are seeing only this lead in a Holter, if there is a big change in axis with a wide QRS tachycardia, then once again think that you could be dealing with a VT. So sometimes in Holter, you have very limited number of leads seen, 1 or 2 or 3, and you have to make a diagnosis. This change of axis, which is more than 40 degrees, again tells you that you are not dealing with the aberrancy, but you are probably dealing with a VT. Here is one such example. Now this tachycardia is not so broad. Yeah, what is not so broad? Something that is between say 100 to 120 milliseconds. If it's a not so broad tachycardia, but a supraventricular rhythm never has a discordant axis. So here it's a right bundle branch block tachycardia with a left axis or almost a northwest axis. If that's the case, this is a VT, and this is a peculiar VT which is called as a fascicular VT. This one comes very close to the left posterior fascicle, and that's the reason when the VT originates close to the conduction system, it tends to have a relatively narrow QRS. So discordant axis to the bundle branch block pattern. It's very important to remember this. This will help you a lot number of times. When this is there, you can say it's a VT. A concordant axis to the bundle branch plot may not be so diagnostic, but a discordant axis is definitely. Then you should look at the QRS morphology carefully. So you know, these wider QRSs, these don't fall into any bundle branch block pattern. Now you may think this is V1 is positive, so it's RBPB, but your RBPB never has a positive concordant pattern, right? You may look at this QRS, you have a LBPB type of pattern in V1, but your normal LBPB never has a negative concordance in V1 to V6. So you may think that the V1 has a particular bundle branch block pattern, but if you look at all leads, this bundle branch block pattern is not typical bundle branch block pattern, and therefore it is not likely to be. For example, you look at this is a left bundle branch block pattern, but look what you have in V4, V5, V6. You have a QR pattern. Your typical left bundle branch block never has this pattern. Look at this one. Here you may see it's a right bundle branch block pattern, but you never have a QS in V6 in a right bundle branch block. So if you do not have a typical bundle branch block pattern, the QRS morphology is not typical for a bundle branch block pattern, then it tells you that it is very likely to be a VT. For example, RS-R' is a triphasic pattern, is usually suggestive of a supraventricular rhythm. So if V1 has a RS-R' or RR', it may suggest a supraventricular rhythm. But if it has single monophasic R, then it could still be, you should strongly consider VT as a possibility. So here is what I wanted to tell you. If you look at the QRS morphology, for example, if it's RBBB shaped, if you have a QR pattern or a monophasic R in V1. So as I said, if it's a SVT, usually it has a RS R dash pattern in V1. But if it is a monophasic R or if it's a QR pattern, despite it being a right bundle branch block type morphology, you can conclude that you are dealing very likely with a VT. Again, this is a very important sign. If your S is deeper than the R in V5, V6, you do not have all the forces moving away from the apex ever in a supraventricular rhythm. So if you have a S which is deeper than the R, then it is very likely that you are dealing with a VT. So these are quite nice and quite specific signs that if you see them, you can consider that you are dealing with a VT. For example, look at this example. You have a RBBB right axis, so the axis doesn't help you. But the moment you look at V5, V6, it has more deeper S. So therefore, it is very likely that this is a VT. Actually, you may not need to take so much trouble because if you are careful in this lead, you can already see that there is a VA dissociation. So once there is a VA dissociation, you don't need many more signs. But not always you can pick up a VA dissociation well, because in the broad QRS tachycardia, those QRSs are so huge that it's difficult to find the P wave. In that case, you must know some other signs like this. For example, there is a deep S in V6. So therefore, it is very likely to be a VT. Once again, one more example, right bundle branch block pattern with the right axis. So the axis doesn't help you. You can't look at the VA dissociation in this broad QRS tachycardia all over. But what I certainly see is that the V5, V6 have a very deep S wave. That cannot happen in a typical right bundle branch block pattern, and therefore it is a VT. LPBB shaped VT, this is what you must know: a small fat R, R which is fat, so it's more than 30 milliseconds, a downstroke which is slurred. So this takes some good reading of the ECGs to pick up this size in LPBB kind of a wide QRS tachycardia. So if you have big fat R, if you have slur on the downstroke, then it helps you to say it's a VT. But you have to see a number of ECGs that train your eyes or train your mind to carefully look at them. I'll show you some examples here. For example, here there is a big fat R, and there is a certain intrinsic oil deflection which is more than 70 to 80 milliseconds. See, look, this is a nice way to study it. There is a big fat R, and if you look at this slur, this is very slow. If the initial activation of the ventricle is slow, then it is very likely to be VT. Once again, one more example where there is a slur in the downslope, and this intrinsic oil deflection is more than 70 milliseconds. Additionally, these QR patterns, I'll stress on them later, but therefore the big fat R and the slur on the downslope makes it a VT. So this is what I think we said, that you need to see this slur on the downslope, an intrinsic oil deflection that is delayed. So more than 70 milliseconds, this blue bar is more than 70 milliseconds, and there's a slur on the downstroke. If you see these signs in LPBB kind of a wide QRS tachycardia, it helps you to call it a VT. I think I already showed you some of the example of concordance. If you have a negative concordance in the precordial leads, you know almost from your undergraduate days that you must call it a VT. A positive concordant pattern helps you, but not always, because there are certain supraventricular tachycardia differential diagnosis in relation to a left posterior axillary pathway. So that, but negative concordant pattern would always be helpful, and it would tell you that it's a VT. This is one important thing that I wanted you to be conveyed, that QR pattern. So whenever you see a QR pattern in any wide QRS tachycardia, QR pattern, so not QS pattern. A QS pattern doesn't tell you much, but if you see a QR pattern, it tells you that this complex is created in the presence of a previous infarction. So this right bundle branch block kind of a tachycardia is with an old entry wall infarction, because you see a QR pattern in V1 to V3. So diagnosis of wide QRS tachycardia is not necessarily limited only to say whether it's a VT with SVT, but if you diagnose a VT, you can also say a few things about, what is the etiology of the VT. Most commonly, it's a post-infarct scar. Most commonly, it's dilated cardiomyopathy in your day-to-day practice. But a QR pattern tells you it's not dilated cardiomyopathy, but it's probably a old entry wall scar, which is probably a old LAD-related infarct. So very important to read this QR pattern. Now, once again, see here, this is a QR pattern in V1, V2, V3 in a wide QRS tachycardia of RBBB morphology. And again, this is a VT in the presence of an entry wall infarct. If you look at this, you have a QR pattern in 2-3 AVF in a LVPP kind of QRS tachycardia. So this VT happened in the setting of an old inferior wall infarct. The moment this patient comes to sinus rhythm, you can read the QRS and confirm that confirm the infarct location. So once again here there is a VT with a QR pattern in say V2, V3, V1, V2, V3, V4, and you can identify this as a VT in the setting of an old anterior wall infarct. So you can even decipher the etiology of the VT. On the other hand, you have some VTs which are with a tall R in 2-3 AVF. So you have something called as an idiopathic outflow tract tachycardias. The most common site is a right ventricular outflow tract, so therefore it's a LBBP type of a morphology, but you have tall QRS complexes in 2-3 and AVF. So this is an outflow tract VT coming from the right ventricular outflow, and this is an idiopathic VT. What is the difference in the idiopathic VT and some of the other VTs that I showed you in the setting of structural heart disease is that it is not associated with risk of sudden cardiac death. And unlike other VTs in structural heart disease, which usually require an ICD implantation, this one can be ablated successfully. Then you have, as I showed you one of the examples, this is again one more idiopathic VT originating close to the left posterior fascicle. So it is from the left posterior fascicle, so you have a right bundle branch block type morphology in V1, and you would have either a left axis as in this example, or you would have a northwest axis as in this example. So therefore an idiopathic VT, also called as a fascicular VT, is usually with a right bundle branch block and a left or a northwest axis. One peculiar example of a LBBP type of a tachycardia is this one. Whenever you have a VT originating from the left ventricle, you have a RBBP morphology. When you have VT originating from the right ventricle, you have LBBP morphology. And there are not many etiologies of VT originating from the right ventricle. The most remarkable is obviously arrhythmogenic right ventricular dysplasia, and patients who have this dysplasia remitted to the right ventricle usually have the LBBP kind of a VT. So it helps you, the wide QRS tachycardia after you diagnose a VT also provides you clues, as we discussed just now, about the underlying etiology of the VT. But this is very common sense medicine. This is very common sense medicine. When this patient comes to sinus rhythm, if you see a pre-existing bundle branch block and your VT is of the same bundle branch block, very likely that you are dealing with the SVT. If you see a pre-excitation in sinus rhythm, very likely that what your wide QRS tachycardia was an SVT, pre-excited rhythm. If you're an old myocardial infarction, then believe me, take this 1 point home and I have done my job. If you're a patient with old myocardial infarction as a wide QRS tachycardia, it's going to be a VT 85 to 90% of the times. If somebody has AV conduction disturbances, known AV conduction disturbances, this patient cannot sustain a SVT at a fast rate because he already has a AV conduction problem. And therefore, in person with AV conduction disturbance, if you see an wide QRS tachycardia, it's very likely to be a VT. So this is very common sense medicine that you should look at when you get to see the ECG in sinus rhythm. Let me conclude here to say that VTs, wide QRS tachycardias, are more often VTs than SVTs. So it's a very important point. But you look at the patient clinically when you stand in the emergency room. If he's hemodynamically unstable, you try and discover what it is later. First cardiovert, get to sinus rhythm, and then start thinking. Never reject a VT as a diagnosis because wide QRS tachycardia patient was hemodynamically stable. That's absolute flawed understanding. SVT can also have a great drop in blood pressure when it starts, and patients can be syncopal. Similarly, a slow VT patient may walk into your casualty being more dyspneic rather than complaining of palpitations, because a slow VT usually leads to worsening of heart failure. So they present a little differently. If his hemodynamic is, so to say, stable, does not mean that it cannot be a VT. So don't have that flawed understanding. Once again, whenever you have a doubt in a wide QRS tachycardia, don't use verapamil or adenosine because the patients can crash with this. It is better to use procainamide if you have any doubt. We don't have that. So we'll end up using either amiodarone if the patient is hemodynamically stable, or attempting the cardioversion if patient is hemodynamically unstable. So that's a fair strategy in an emergency setting. But you will need to take a call at some point in time later whether it was a VT or SVT, because there is a world of a difference in the treatment. SVTs can be ablated many a times. VTs in setting structural heart disease require ICD. almost all time. So you need to be certain, if not in the emergency room, later in your hospital course, as to whether you dealt with a VT or a SVT. I think I'll stop here, and we may have questions now or later. But let me once again thank Dr. Darshan Banker for this opportunity. Thank you very much. Thanks for your patience.
Wonderful lecture, Ashish. I think that was really nice. And your few points that you mentioned of how to differentiate wide QRS tachycardia were beautiful. The way you said that you should look at the P waves in the lead which has the narrowest QRS. I think that is really very important. Then the fact that you should look for discordance of the axis bundle branch block pattern. That was really nice point. And of course, if you are not having a very typical bundle branch block, like positive or negative concordance.
I think you summarized it perfectly, Bhavesh. I need not have spoken after you. It is not the width of the QRS that helps, but it is precisely the points that you enumerated that takes you through. Thanks.
Great. Are there any questions?
No, sir. No question as of now. Maybe.
So one question from my side to Ashish. Ashish, you said that whenever in doubt with a wide QRS, you do not give verapamil and you do not give adenosine. So we know that we do not give verapamil because, of course, if there is LV dysfunction in a patient with VT, worsen, and hence we should not be giving. But what about adenosine? Most people believe it's a short-acting drug, acts for only a few seconds. If it works, fine. If it doesn't work, it doesn't do any harm. So what is your take on this?
Many a times, yes, although I have said that it may not be, it may not lead to a harm most of the times because it's a short-acting drug. So within a few seconds, the effect is lost. But you can hardly, I mean, if it terminates, yes, you can call it a SVT. But if it doesn't terminate, it still leaves you with a differential diagnosis of some other supraventricular tachycardias like atrial fibrillation or atrial tachycardia. Yes, you may have a slowing of the rate and then you may see more P waves, and that helps you to diagnose. VT obviously will not be affected at all. So it may not be harmful necessarily all the times, but only a termination will clinch it for you, and not necessarily if it doesn't affect the VT. Many a times these patients are so sympathetically overdriven with the tachycardia that adenosine may not even act enough, or you may require much too higher dose.
So the question is relevant because a lot of doctors are a bit hesitant to cardiovert in their ICU or in their hospital. There is a belief that the patient may go into an asystole, or the patient may have an embolic stroke and so on. And they are, of course, not very valid reasons, but this is one of the things which are running in the doctor's mind, and hence they are a little hesitant in doing electrical cardioversion unless the patient is absolutely, down and hemodynamically unstable and, collapsing.
Right. So hemodynamically unstable patients, there should obviously be no hesitancy. You should cardiovert. Where you have a hemodynamically stable patient, we have a difficulty in our places because Cordron you can shoot, but Cordron doesn't necessarily act in a very short time as compared to procainamide, which was available elsewhere in other countries. Procainamide stops the VT if it's a VT immediately. So procainamide acts much faster. Amiodarone or Cordron doesn't act that fast. But then we do not have another option. And as you say, in a hemodynamically stable patient, there is always this kind of a hesitancy related to whatever you said. But in practicality also, one is to make an anesthetist available. Second is to have a patient starving to do that kind of a cardioversion under sedation for a hemodynamically stable patient. So yes, there are these concerns which delay it, but hemodynamic stability should dictate how you go about it.
So would you think that an anesthetist standby is necessary? And second, what about loading the patient with heparin? Is that necessary?
So once you diagnose it as a VT, if the patient is hemodynamically unstable, of course, no intensive.
I'm talking of stable patients.
Yeah, in a hemodynamically stable patient, yes, because they need to be sedated properly and then you cardiovert. You cannot cardiovert a hemodynamically stable patient when he is not adequately sedated. Now, many of our intensivists are anesthetists, so you can bypass the need for an extra anesthetist. But many a times people are dealing it in nursing homes where there are not anesthetists available round the clock, and that needs to be arranged. And secondly, it's about the starvation thing also. The anticoagulation thing is, I think, not relevant, because yes, if you do a echo and see a clot, that becomes a concern. But when you are cardioverting a VT for the risk of it deteriorating into VF, then this is not the concern that you should rule out a clot or you should heparinize.
Good, thank you.
There was one more question from our DNB student, that what is the difference between polymorphic and pleomorphic ventricular tachycardias, and is there any particular difference to treat this kind of patient in day-to-day practice, polymorphic versus pleomorphic VT?
Yeah, certainly. I think polymorphic VT is, if you look at any lead, if there is a beat to bed change in the morphology of the QRS, that is a polymorphic VT. And if you and a pleomorphic VT is where you have different morphologies of a monomorphic QRS complex in the same lead. So you have one discrete morphology, and after a short run of non-sustained VT, you have another type of morphology. Or many times it is with the premature ventricular complexes that you see in a Holter different morphologies of the PVCs, and then you call it a pleomorphic. So it is pleomorphic is the same couple of different monomorphic morphologies that you see in the same lead. So a pleomorphic is similar to a monomorphic for all working purposes, because it is believed to be then scar related, and you may think that the scar is bigger when you have pleomorphic, whereas you may think the scar is more discrete when it's monomorphic, but till you image the scar. And when it is polymorphic, the understanding has to be different, because polymorphic is usually in relation to a couple of etiologies. For example, it may be in relation to acute coronary syndrome or active ischemia, where revascularization may take the precedence. It may be in relation to a drug-induced QT prolongation and torsades, where taking away the relevant drug may take relevance. Sometimes it is in relation to a bradycardia, so you may have to increase the baseline rate to take care of polymorphic VT. And giving amiodarone or cordron in these patients would be obviously harmful. So that's an important message, that when you have a polymorphic VT, you should know in what setting it is. If it is the prolonged QT setting, then obviously amiodarone is going to be harmful. There are some polymorphic VTs which are in the setting of normal QT where amiodarone can be given, but you should know that you are dealing with that scenario. So the indiscrete use of amiodarone, which you often see, should be only after sparing a thought on what is the cause to get into a polymorphic VT.
Okay, so there are two more questions. One from Dr. Nandkishore Panchal. Procainamide availability, I think you already said it is not available.
Right.
From Dr. Rajanya Patel, how to deal with recurrent ventricular tachycardia when patient is receiving recurrent ICD shocks?
Right. So it might take too long to answer this, but let me just give you a guideline that you have to, if you have a recurrent shocks, you must interrogate and classify it as being recurrent appropriate shocks. So because of a VT, or recurrent inappropriate shock because of more commonly atrial fibrillation. And once you know that it is recurrent VT that is causing appropriate shocks, there are a couple of things that you can program the device better, so that the ATPs are used, the antitachycardia pacing therapies are used more often than necessarily shocks. You can program the shocks to a lower strength than a higher strength, so that a discomfort to the patient is better even if he has to get a shock. You can treat by altering the drug therapy, so you may have to reload with amiodarone again, or you may want to add mexilet into amiodarone to get the effect, or you may want to increase the beta blocker dose with amiodarone to get the effect. And the third thing that is often important to understand in a VT storm setting is to achieve a sympathetic blockade. The sympathetic blockade is achieved by either a transcutaneous cervical sympathectomy injection with bupivacaine, or thoracic epidural anesthesia, or with surgical, sympathectomy, bilateral cervical sympathectomy. So basically you need to control, and the medical way of controlling the sympathetic tone before all this is obviously good sedation and ventilation. Not to forget that all anesthetic drugs are quite anti-arrhythmic effectively.
I think Ashish, adding one more point to what you already said, that when a patient comes with multiple shocks, of course, the first thing to do is to keep him in an ICU and monitor him. And once he's in the ICU, probably you would like to switch off the ICD from giving shocks, which are going to be very expensive for the patient, and use, stop that by whatever means, by a magnet or I don't know how. And then if required to shock, then use an external shocking device, so that that's would be better rather than getting frequent shocks and depleting the battery. Do you agree with that?
You should look at it two ways. One is, if it's inappropriate shock, obviously all this you said is automatically in place. If it's an appropriate shock, then obviously you have to make, if you want to switch the device off because the shocks are painful and recurrent and you want to intensify your medical therapy, then obviously you have to make the alternate arrangement that you said, is you have to put the R2 pads and shock from externally, because at the same time you are taking care of the storm by increasing the medical therapy, trying to sedate, trying to ventilate, a number of other things that we discussed just now. So in that setting, you may switch off the ICD and put R2 pads to shock as required, or you may do the pacing, temporary pacing if it is in the setting of bradycardia. So there are these things that you will automatically need to do when you switch off the ICD.
Okay, so thank you, sir, for the very informative lecture.
Thanks.
We will move ahead with our second talk of the day with Dr. Bhavesh Vajifdar, sir, about antiplatelets in current era in 2020. Over to you, sir.
Okay. Thank you very much, Darshan Banker and the entire Bankers Heart Institute, Ronak, and everyone for arranging this nice gathering. Though, of course, I miss being there in Baroda and meeting all of you in person, and having the niceties of Baroda, of Bankers Heart. But we can do whatever we can best with this particular scenario which we find ourselves in, sadly. So let's try to do whatever best possible. So this year the talk which I'm supposed to give is on antiplatelets, and I think last year I also gave a talk on antiplatelet therapy at Bankers, if I'm not mistaken. And but from the last I think it's 10 months or more, there have been a lot of changes which have taken place, and hence I thought it would be appropriate to discuss the newer things in antiplatelet therapy. So just coming to the basics, we all know that thrombus is the cause of acute coronary syndromes, and thrombus in the coronary arteries is the main reason for the high mortality and morbidity of patients with coronary artery disease. And this was seen many centuries ago, and even now we continue to see when we do our primary angioplasty, we see the clot which we remove at times. We know that all the acute coronary syndromes occur because of plaque instability, because of either of erosion or rupture. But what is the primary thing which happens is that the platelet activation takes place, and then there is a platelet aggregation which leads to a platelet plug and a thrombus formation, and that leads to an ACS, and that leads to all the mortality and morbidity of coronary artery disease. So with this background, we all know now that we need to use very potent dual antiplatelet therapy, and now dual antiplatelet therapy, that means use of aspirin plus one another antiplatelet therapy, P2Y12, that is either clopidogrel, prasugrel, or ticagrelor. This is universally recommended for all patients with acute coronary syndromes. And this is a chart from almost 3 years back, 2017, I think, ESC guidelines. And you can see that if you have a patient with an acute coronary syndrome, be it ST elevation myocardial infarction or non-ST elevation myocardial infarction, once you have an ACS, and regardless of what strategy of treatment you do, whether the patient undergoes CABG, whether the patient undergoes angioplasty, whether the patient undergoes fibrinolysis, or the patient is just on plain medical therapy, all of them are advised to take antiplatelet therapy to antiplatelets for almost 1 year. Okay, so this is really important. The important thing is if you have a high bleeding risk, then you could shorten it, and if you have a very high ischemic risk, then you could prolong it. So this is the important thing. While we want a good antithrombotic effect, we don't want the patients to bleed and have complications and perhaps mortality because of a bleed. So it's really very important for us to tailor our therapy based on the ischemic risk factors and the bleeding risk factors. So everyone knows, but I'll just tell you in brief, what are the ischemic risk factors? If you have, it could be either clinical risk factors or angiographic risk factors. So clinical risk factors, patients who has a recent ACS, patient who is diabetic, patient who has had multiple episodes in the past, patient who has a chronic kidney disease. So these are the patients who have a higher ischemic risk factor, means the possibilities of getting problems like MI or an NST elevation MI will be higher in these patients. What are the angiographic risk factors? Patient with a left main disease, patient with a multivessel disease, patient with severely calcified and ulcerated plaques, patients with thrombus burden in them. So these are patients with a high ischemic risk. What about the bleeding risk? We all know the bleeding risk, we can have either the Crusade score or the DAPT score. Basically, they will be looking at patients, whether they have diabetes, whether they have hypertension, they have an ulcer, they have a prior history of bleeding, where the patient has a CKD or a kidney disease. So all these patients are at a higher bleeding risk. So depending on whether you are at a high bleeding risk or a high thrombotic risk, you can classify this patient into 3 types of patients. So you should, whenever you are treating a patient with ACS, you have to classify where your patient is. So if your patient is at a high risk of thrombosis or high ischemic risk and a low bleeding risk, then you should give them a longer DAPT therapy. If you have the vice versa, that means the bleeding risk is high and the ischemic risk is not high, then you could give a short duration DAPT. That means you don't want a lot of bleeding to occur. But unfortunately, a large number of our patients will have both a high bleeding risk and a high ischemic risk. This is really very common. And then we do not know what to do. And now we are looking at some of the answers which will perhaps help us to treat these patients better. And there are quite a few trials in the last 2 years which give us some idea of what we can do. So these are some of the trials which I'm going to share with you. This is a trial called as EVOLVE Short DAPT trial study. And here they took elderly patients who were at a high risk for bleeding. And these patients, what they did is that at the end of 3 months, they stopped the P2Y12. That means either clopidogrel, prasugrel, ticagrelor, or whatever they were taking. So the second agent was stopped at 3 months and only aspirin was continued. And they found that this was quite a safe strategy. Similarly, there was another study. This is Onyx 1. This is regarding one of the newer generation stents. And here they stopped the second antiplatelet within 1 month. So 1 month of dual antiplatelet therapy. And then because the patients were at a high bleeding risk, they stopped the second antiplatelet. That means aspirin was continued, but either the clopidogrel or ticagrelor or whichever one, that was stopped. And again, these patients did fairly well. Then we are coming to a newer era. So now, whenever you used to stop the dual antiplatelet therapy, you would continue only aspirin. But now we are looking at stopping aspirin and continuing the other agent, be it clopidogrel or ticagrelor or sometimes even prasugrel. So let's see what evidence we have. So this is a trial called Stop DAPT-2. That is the second part of the Stop DAPT trial, which we discussed earlier. And here what they did is nearly 3,000 patients, large number of patients, we underwent an angioplasty, and at the end of 1 month, they were randomized into either getting aspirin plus clopidogrel, that is the standard dual DAPT for the next up to 1 year, or stopping the aspirin and continuing only clopidogrel. So at the end of 1 month, you divide either aspirin plus clopidogrel or only clopidogrel. And what did they find? That if you stopped aspirin and gave only clopidogrel, then the bleeding was much less. That means this was really superior. The bleeding was less, major bleeding. And at the same time, if you looked at the cardiovascular death, MI, thrombosis, stent thrombosis, stroke, which you expect that because you are reducing the antiplatelet treatment, where sometimes you would think that this would cause an increase in all this. But the trial shows that the difference was not much. This was not significantly different. Both the two arms had the same kind of a cardiovascular death, MI, stroke, and so on and so forth. So this was a non-inferiority of the single antiplatelet, that is clopidogrel. So this trial advocated that after the end of 1 month, if you have high bleeding risk, you can switch only to clopidogrel, stop aspirin, and the patient would do fairly well. One more trial, the SMART choice, again 3,000 patients, and here again undergoing PCR or angioplasty. And here after an initial 3 months, so the first 3 months you give dual antiplatelet therapy, aspirin plus the other drug. Majority of the patients, the drug was clopidogrel. Some patients were on ticagrelor and also very few on prasugrel. But what happened when you stopped this aspirin? They found that if you, the similar kind of a conclusion, if you gave only P2Y12 monotherapy, that means clopidogrel or ticagrelor or maybe prasugrel, and if you stopped aspirin, then the bleeding was less, and at the same time the death, MI, and stroke was not high. So again, the same conclusion. If you are not going to have lots of problems and you are going to reduce the bleeding, then why not go to a single therapy, and that too without aspirin, but continuing the other drug. Then recently again a few trials which have come, the Themis, Twilight, let us look at them, and they were mostly about ticagrelor. And here is the first trial, this Themis trial. And we all know that in stable coronary artery disease, unless if they are going for a procedure like an angioplasty or a bypass, then you give dual antiplatelet agent. But otherwise, if you have a person who has a stable coronary artery disease, that means for the last 1 year or more, he has not had an unstable episode, he has not undergone an angioplasty, or he has not undergone a bypass. So in the last 1 year, the patient has been stable. So in such type of patients, currently, we only give a single antiplatelet therapy, and that too usually it's aspirin. But here, they have tried to see whether we can use ticagrelor or dual antiplatelet therapy or monotherapy in stable patients with coronary artery disease. So here, the hypothesis was that if you have a patient who is diabetic, then he could be having a prothrombotic state. And if a diabetic has a prothrombotic state, it's possible that he could be at a higher risk of adverse events, and hence probably more antiplatelet therapy would be beneficial to him. So with this hypothesis, they included 19,000 patients and they followed them up for nearly 40 months, means 3.5 years. And what are the kind of patients they took? They took diabetic people who were elderly, so 50 and above, okay? And they had to be stable coronary artery disease. If they had a MI or stroke, they are excluded. So they were randomized into 2 arms. So one, the standard arm of only aspirin, that is what is usually given with a placebo, or they added ticagrelor to them. So aspirin plus ticagrelor. And let's not go into this. And look what happened. If you look at the primary endpoint, that means if you look at the cumulative event rate of cardiovascular death, MI or stroke, the ticagrelor arm, means where you have added ticagrelor to aspirin, fared much better than placebo. Okay, and the p-value was significant here, okay, 0.038. But at the same time, if you look at the bleeding is increased. So the bleeding has increased significantly when you add ticagrelor instead of placebo to aspirin in stable coronary artery disease patients. The bleeding has increased significantly. So then we were wondering whether it is good to give ticagrelor or not. But then they analyzed it further, and they found that fatal bleeding was not different, though large bleeding was different. So if you look at major bleeding, it was high, but it was not fatal. So fatal bleeding was not different in the 2 groups. So similar findings in the patients who underwent PCI in this group, that they found that the fatal bleeding is less. So they concluded that if you look at the net clinical benefit, that means if you remove the bleeding and you see what are the benefits of the ischemic event prevention, and if you subtract the bleeding events from that, then you get the net clinical benefit. And then you found that if you look at the entire population, then there is a net clinical benefit. That means you might have some more bleeding, but because it is not a fatal bleeding, you are actually preventing many ischemic events, and hence it might be beneficial to give ticagrelor to these patients who have stable coronary artery disease but who are diabetic and elderly. Okay, so based on this very robust trial, ticagrelor was recently approved in June 2020. It was approved in the US by the FDA to reduce the risk of first heart attack or stroke. That means for primary prevention. So ticagrelor now can be used as a primary prevention in patients who are at high risk, not for everybody. So it's not for all patients for primary prevention, only patients who are at high risk. So maybe diabetic people, elderly people, and so on and so forth. So this is an approval which ticagrelor has recently got. And then we move on to the next trial. There is the Twilight trial, in which they were again evaluating ticagrelor with aspirin or ticagrelor alone in high-risk patients after a coronary angioplasty or intervention. So again, a very robust trial. Over many countries were involved, lots of patients. And what they did was initial first 3 months. So after an angioplasty, for the first 3 months, they all received ticagrelor plus aspirin. So everyone got a dual antiplatelet for the first 3 months. And mind you, these were all high-risk PCI patients. Okay. And after 3 months, if they were stable, of course, if they were unstable or if they had a problem, then they go out of the study. But if they were stable for 3 months with this dual antiplatelet therapy, aspirin plus ticagrelor, then what they did is after 3 months, in half the patients, they removed the aspirin here. So that means ticagrelor with placebo. And in the other half, they continued aspirin and ticagrelor both. And they continued this for 15 months and more. And let's see what happened. Okay, so they were looking at bleeding and they were also looking at all these cardiovascular problems. So as was expected, if you look at the primary endpoint of bleeding, okay, so the bleeding was much more when you were giving aspirin plus ticagrelor. So if you give ticagrelor and aspirin combination for 1 year, then you will have 7% bleeding. Remove aspirin, that means ticagrelor is continued, but aspirin is removed, then you are going to reduce the bleeding. So when you remove aspirin from the DAPT after 3 months of stable patients, then you are going to reduce the bleeding. But is there a cost to it? Are the patients going to have more death, MI or stroke? Are they going to have more? No. So here the trial tells us that there was no difference in the two. That means you had less bleeding, but you did not have more complications of death, MI or stroke. So based on this trial suggested that at the end of 3 months, even if you have undergone a high-risk PTCA, then after 3 months, it could be safe to drop aspirin and continue only ticagrelor for the next 12 months. So this is what they concluded, that antiplatelet strategy of containing ticagrelor monotherapy had less bleeding without increasing the ischemic events for a period of 1 year. Similarly, in the diabetic subset, they found a similar thing. I don't have to go into the details of all this. The same kind of a conclusion was there in patients who were diabetic in this subset, and also patients who underwent very complex PTCA. That means patients who had 3-vessel disease undergoing angioplasty, patients who had many stents, who had long stents, who had bifurcation lesions, who had a rotablation done, a left main, so a bypass graft intervention, a CTO intervention. So very complex angioplasty patients. In these patients also, at the end of 1 year, the patients whom aspirin was dropped fared better. So that means give only ticagrelor. First 3 months, give aspirin plus ticagrelor. After 3 months, drop aspirin and continue only ticagrelor. You will be better. Then there's a trial called as a TICO trial. And then again, same thing, ticagrelor with or without aspirin. And this is a Korean trial. And this is about 38 centers in Korea. And the objective was to test ticagrelor monotherapy in patients after an angioplasty. They particularly used only one type of a stent. And this is it's a complex thing. Don't try to look into it. Just follow what I'm saying. For the first 3 months, everybody got a dual antiplatelet therapy. That means they got the conventional aspirin plus ticagrelor, both of them. At the end of 3 months, if you are stable, then in half of the patient, the aspirin was stopped and you continued only ticagrelor monotherapy, just like the previous trial. And in the other half, you continued both aspirin plus ticagrelor for full 1 year. And again, they looked at the same things. And here they have one more new definition they got. And they said, why look separately at bleeding and why look separately at major MACE events? So they have coined a new phrase, that is NACE, that is net adverse clinical events at 12 months. So that means it also includes major bleeding along with our cardiovascular MACE things. So major bleeding plus all-cause death, myocardial infarction, stent thrombosis, stroke, or TBR. It's a really a very robust kind of adverse outcome event. So NACE is what they called it. And here's what they found, that NACE, if you have ticagrelor monotherapy, then this patient did better. They had less NACE as compared to those who had a monotherapy. So a dual antiplatelet therapy. Similarly, for bleeding, the bleeding was less in patients with ticagrelor. The MACE events were almost similar. The p-value just about 0.09. You know that 0.05 is less than 0.05 is significant. So here 0.07 and 0.07, so not significant. So the conclusion was the same. If you give ticagrelor monotherapy, you're reducing the bleeding, you're not increasing the ischemic risk, and possibly this should be the strategy in patients who are having high bleeding risk or even otherwise. Then coming to a slightly different role of antiplatelet therapy, this is in patients with stroke. So here, this is the THALES trial, which is again released in July in the NEJM. And what it did is it took patients who had a stroke or a TIA. Mind you, these were the patients with a very mild stroke. This was not patients with a very severe stroke. So patients with a mild stroke, NIH score less than 5, or they had a TIA. Okay, these kind of patients were taken and they were given either ticagrelor plus aspirin or placebo plus aspirin. So the standard thing of only aspirin or addition of ticagrelor. And you looked at stroke or death within 1 month. And here you found that patients in whom you have added ticagrelor to aspirin, they fared better than those who are only having aspirin. The p-value is significant here. Okay. And what about the secondary endpoints? Ischemic strokes, that were also less here, and the disability was similar in both the groups. The bleeding was high, of course. The p-value was significant. If you add ticagrelor to aspirin, the bleeding was much higher, highly significant. But then if you look at the net clinical benefit, it seemed to be in favor of adding ticagrelor. Okay, so this is one more recent trial. And lastly, I would like to end the talk with this one particular recommendation, which has come just 5 days ago from the recently concluded digital ESC 2020 meeting at Amsterdam. And this is a particular slide which talks of patients who have atrial fibrillation. I will explain to you everything. Don't try to, concentrate too much on the slide. So you have patients who have atrial fibrillation and they have undergone an angioplasty. So normally when you know patient with atrial fibrillation, you need to give them anticoagulation. And initially we used to give them only acetrom or warfarin. And then we said we could give, instead of acetrom or warfarin, we could give a NOACS, the newer ones, apixaban or dabigatran, or the other ones, rivaroxaban. And now we know that these are actually preferred over vitamin K antagonists. So if these patients with atrial fibrillation undergo PCI, they should be on a NOACS. That means they should be on the newer oral anticoagulant agent. And of course, because they have a PCI, they should also be on a DAPT. That means aspirin plus a second drug. So initially, we used to give this therapy, triple therapy as it is called, means oral anticoagulation plus 2 antiplatelet agents, was given for 1 month. But now they have downgraded it to only 1 week. That means you keep the patient in the hospital for 1 week. And during that time, you give all these three, a masala of all three potent drugs to prevent embolism and to prevent stent thrombosis. But after the first week itself, you could downgrade in some of the patients. So here you break the patients into patients with high bleeding risk, patients with high ischemic risk, and normal patients. So in normal patients, you could just downgrade from a triple therapy to a dual therapy. That means 1 NOACS and a single antiplatelet, whichever you could use. Mostly we use clopidogrel. So normally we use clopidogrel with 1 NOACS. So after 1 week of therapy, straight away downgrade. What about patients who have a high bleeding risk? So if you have a patient with a high bleeding risk, then again you downgrade immediately. Okay, and how do you downgrade them? You downgrade to a NOACS plus a single antiplatelet agent, and that to be given only for 6 months. Okay, so only 6 months, not 1 year. Earlier it was 1 year. So you come down to 6 months, and after 6 months, up to 1 year, only a NOACS, and beyond 1 year, of course, everybody, after 1 year, once the patient is stable for 1 year, there is no role for any antiplatelet in these patients. You can continue only a NOACS. You can stop aspirin, you can stop clopidogrel, you can stop all antiplatelet drugs. You can only give them either dabigatran or rivaroxaban or apixaban or whatever. But if you have a high ischemic risk, that means we described patients which suppose have a left main stent, have a triple vessel disease, multiple stents, bifurcation stents. So these patients, you could prolong the triple therapy, that means NOACS plus DAPT for 1 month, okay? And then after 1 month, then you downgrade them to a dual therapy with a NOACS and a single antiplatelet. And after 1 year, you come down to only a NOACS. So in general, there is a lot of new things which are happening for antiplatelets. We are looking, because we are having better stents, because we are having better results of angioplasty because of various newer interventions. So we are looking at being able to reduce the duration of a dual antiplatelet therapy. And at the same time, we are going for a longer monotherapy. Initially, the monotherapy used to be only aspirin. Now we are changing from aspirin to clopidogrel and perhaps to also ticagrelor. These are the more potent drugs. We are also able to use the newer antiplatelet drugs in patients with stable coronary artery disease, provided that they are at a high risk. Okay, not all patients with stable coronary artery disease, and also in patients of stroke, that is a small strokes, not the large strokes, the small strokes. Perhaps there is a role for ticagrelor as a secondary prevention, but that is not really very clear. We will have to wait for larger trials to tell us what is happening. With that, I end my talk. Thank you so much.
Hello. Hi, Bhavesh.
Hello. Hi, Darshan. How are you?
Oh, fine. Very nice talk, Bhavesh. It was wonderful. I have two questions. One is, does this guideline of atrial fibrillation will apply for PAMI patients with a LV thrombus? If you have done a LAD-plasty and you find a LV thrombus afterwards, what will you consider? And my second question is, where do you see role of prasugrel?
Okay, so
in Indian scenario especially, because
perfect.
Still yeah.
Because of the cost you are saying.
Yeah, absolutely.
Okay. So first, coming to your first question is about the presence of a thrombus in the left ventricle, and you have done an angioplasty. So we know that patients with LV thrombus because of an infarct, usually we usually give oral anticoagulation for 3 months usually. And beyond that, usually there is the clot gets organized, and then the chance of thromboembolic episodes are less. So it's 3 months. However, if the patient is already on oral antiplatelet therapy, then perhaps 1 month would be the right thing, because the bleeding risk would be quite high with all three together. Perhaps if you have a low bleeding risk, you could extend to 3 full months. I don't know. I'm not aware whether there is a data and a recommendation to this particular question of yours. But if it is my patient and if there is a bleeding risk is not high, then I would continue triple therapy for 3 months. If at the end of 1 month, if I do an echo and if I see that the clot has dissolved or has layered and become endothelialized, then I would probably stop at 1 month with the triple antiplatelet therapy. But beyond 3 months, I don't think there is any recommendation for triple antiplatelet therapy.
And prasugrel?
As far as prasugrel is concerned, I think the prasugrel, the clear-cut indication is only for patients who are undergoing an angioplasty. So prasugrel in patients with medical management only is hardly there. So you use prasugrel only in patients who have undergone an angioplasty. Now, if you compare clopidogrel, prasugrel, and ticagrelor, then we know by various analogies, there may not be a straight head-to-head trial, but we know by various analogies that prasugrel and ticagrelor are more potent, more faster acting, and hence could be preferred when there is a high ischemic risk as compared to clopidogrel. Now, if you were to compare between ticagrelor and prasugrel, because prasugrel is a little longer acting drug, that means if you need to stop the action of prasugrel, it takes 7 days for the prasugrel effect to go off after you stop prasugrel. While as if you look at ticagrelor, it's only 3 days. So that's a major difference. The cost-wise, now you know that ticagrelor has gone off-label, and there are so many companies which are offering ticagrelor at really very, very low prices. So I think in today's world, perhaps we would be looking more and more towards ticagrelor unless the bleeding risk is high. If the bleeding risk is high, then probably you could go to clopidogrel. But I think we could be shifting more and more patients towards ticagrelor as opposed to clopidogrel, and definitely more so than prasugrel.
Yeah. So one more question. Your views on antiplatelet therapy in patient with idiopathic asymptomatic thrombocytopenia post-angioplasty?
I think the easiest thing would be to refer to a hematologist. So I think the answer is very difficult. I don't know the right answer. We see patients who really go down with their platelet counts, and sometimes they drop to 5,000, 10,000, stuff like that. And I don't know whether there is a clear-cut guideline. I don't know if the other panel people would be able
there is like we know for Ronak, we can follow the guidelines what we have in like dengue fever and all that things.
Yes,
if your platelet count is about 90,000, then continue both antiplatelets. If it is between 90 to 60, still you continue with a lot of vigilance to dual antiplatelet. Between 30 to 60, you continue single antiplatelet, and less than 30, you have to stop both the antiplatelets.
So yes, so I think that's a very good kind of things to follow. Of course, I don't know whether these guidelines apply to patients.
It is not a guideline; it is general consensus, and there are a lot of papers which has come up for this thing.
Sure. I think it could be a good strategy, but I think these patients now looking at the newer data which is coming. So at the end of 1 month, if the patient don't have a very high ischemic burden, then I think after 1 month we would straight away switch to a single antiplatelet, and perhaps I would prefer clopidogrel. But I could be right or wrong. Don't know.
Okay. Sir, any views on use of ticagrelor 60 milligram tablets in post-ACS or pre-ACS, primary versus secondary prevention?
Okay. So for primary prevention, there is no data because we still don't know whether ticagrelor should be given to all patients for primary prevention. So stable coronary, if that is what you are asking. But if you are looking at post-PTCA patients, post-ACS patients, and if you want to continue a dual antiplatelet therapy beyond 1 year, then you could, come down from 90 to 60 milligram BD along with aspirin. But now with the newer data, whether you would want to straight away drop aspirin and continue with 90 milligram BD monotherapy with ticagrelor, rather than, going down to aspirin 75 plus ticagrelor 60 plus 60. I think there could be some answers in the future, but currently there is no straight away answer. Personally, if you ask me, I am not using 60 milligram dose, but there are many of my colleagues, including some very senior consultants who have a large practice of angioplasty, and they are beyond 1 year, they are putting their patients onto 60 milligram BID with fairly a good result, I think. But personally, if I think I have to continue ticagrelor, I give it 90 BD. And now with the new data coming in, perhaps I would stop aspirin and continue ticagrelor 90 BD if they have a high ischemic risk.
Okay. So I don't think we have any more questions. So we should go ahead with our third lecture with Dr. Darshan Jhala, sir.
Thank you.
Sir, over to you, sir.
Thank you, Ronak. Thank you, Dr. Banker, and participants. It's good to participate in such a nice academic talk. And after having listened to Dr. Vajifdar on one aspect of thrombosis, I will be talking on the other aspect of thrombosis. So basically, I'm going to talk about the importance of NOACS, especially those NOACS which have a reversal agent available. Now we have basically 3 NOACS available to us.
Share your PowerPoint slides.
So your slides are not visible.
Not visible?
No.
So
right.
you have shared your, not the correct, when you go to the share option. Bhavesh Thakkar, you can maybe tell them.
Yeah. When you go to the share screen, you will have to select your PPT.
This is my PPT.
No, right now what is visible is your browser. You can once again click on share screen.
Okay.
You can stop screen share and again do it.
Yeah, okay. Okay. Now?
Yes, perfect.
Okay. So basically we will be talking about NOACS, and between all 3 of them, how do we particularly select a particular NOAC? There is a lot of talk about using NOACs who have reversal agents. Are they really relevant in our day-to-day practice? Or we can just go ahead and use any NOAC that we want, regardless of whether they have a reversal agent or not. So this has become quite a confusing issue, especially to people who are practicing out there and who have a recent or not a very extensive exposure to NOACs. Now, we encounter standard patients in our practice who require a novel or an oral anticoagulant. I'm not talking about antiplatelets, I'm talking about oral anticoagulation. For example, people with non-valvular atrial fibrillation who have a significant ischemic and an embolic risk as calculated by these scores which are available to us, that is SHADS and SHADS-VAS score. So if such a patient walks into our clinic, we have 3 choices. We can either use dabigatran, actually 4, because dabigatran has 2 doses. So we can use dabigatran, we could use rivaroxaban, or we could use apixaban. So between the 3, there are a few situations a particular drug is preferred. For example, if you have low renal function, then you would probably prefer apixaban. If you have a very elderly patient, then also you might prefer apixaban. If you have high GI bleed, you will not use rivaroxaban and you might settle for a lower dose of dabigatran and apixaban. Barring these situations, the majority of our patients, all 3 drugs are available to us. So then, do we choose a particular agent which has a currently available reversal agent or not? Or we just go ahead and use whatever drug we prefer to use. So to put this thing in perspective, let us go ahead with some basics of NOACs in recapitulating their role and their pivotal studies. So we see that all NOACs, dabigatran both the doses, apixaban both the doses, and rivaroxaban both the doses, are all much better in reducing stroke and systemic embolization when compared to a standard drug like warfarin. So this much is established. that all three drugs work better than warfarin when it comes to efficacy. When we come to major bleeding, we realize that rivaroxaban is right on the center. So it's not better than warfarin. It is an effective drug, but it can cause as much bleed as warfarin therapy. In these situations, apixaban and lower dose dabigatran are superior. They have equal efficacy and they are less bleeding. Dabigatran 150 is also same bleeding as warfarin. So we know that these drugs are effective, but there are situations where they might cause more bleeding. And then we'll have to decide between the various doses and various drugs. So if there is a higher bleeding risk, one would not like to use rivaroxaban. All drugs reduce intracranial bleed, so this is good news. But barring that, there are other bleeding episodes, not just intracranial bleeds, which we have to face as clinicians. And that is why, if you're looking at intracranial bleeds, there is no reason to choose anything over the other. Of course, dabigatran and apixaban still are better than rivaroxaban. So the bottom line is that dabigatran and apixaban seem to be favoring less bleeding, and they are as effective. Okay, so this is the graphical form between major bleeding and all-cause mortality. So once again, you can see that dabigatran and apixaban score over rivaroxaban when you're talking about bleeding. Remember, rivaroxaban is an effective drug, and in things like venous thromboembolism, it is probably the drug of choice. But it has a little bit more bleeding episodes than dabigatran and apixaban. So when we have these two competing drugs, dabigatran and apixaban, which one do we choose? Now, what is the clinician's concern about starting anticoagulation? The greatest fear that the clinician has is that my patient will bleed. And bleeding is considered to be such a dangerous, though not always, but it is perceived as such a dangerous thing because it is visible and it is seen, and the patient gets panicky. And in the presence of bleeding, what happens is that all drugs are stopped. So the patient from a bleeding risk goes into a high thrombotic risk. So this is a paradox which we have to address in our day-to-day practice. So basically, the clinician wants to avoid bleed at any cost. So what he does, he reduces the dose. So when we were in trials, dabigatran was using 2 doses in equal form, so that was not a problem. In phase 3 trials, we had 80% of patients in proper dose, and only few patients were on the lower dose. But when you come to real world, it is bad, because those who require anticoagulation don't get it. So from 20% of rivaroxaban low dose, it went to 40%. And all this because the clinician out there wants to avoid bleed. So basically what we land up is, we do not use recommended doses, but we have a tendency to use lower doses in many more patients as compared to what was there in the trials. And so what does the clinical outcome of reducing the dose happen? So when you reduce the dose, the efficacy goes down. Of course, the bleeding becomes a little less, but death and strokes and ischemic episodes are now increasing when you reduce the dose. So it is not a good idea. You are giving an anticoagulant to reduce the ischemic stroke and the systemic embolization. You land up in the practice reducing the dose and you are back to square one. So what happens is, you are taking the side effects of an anticoagulant without actually getting the benefits of, just because you managed to reduce the dose. And when you look at the cause for reducing the dose, the concern is my patient will bleed. And another problem with NOACS is that when a NOAC patient bleeds, there is no specific anticoagulant. This is what the clinician goes with. The clinician has been in touch with warfarin. He knows that I can stop warfarin, give vitamin K, give fresh frozen plasma, give blood transfusion, platelet transfusion, and the bleeding will stop. But with a NOAC, it is a new drug. He has been told that there is no anticoagulant, and there is no antidote available. And the another thing that scares him is that he has no way to monitor the effect of anticoagulation. So in order to get confidence of no bleeding, he reduces the dose. So basically, if you look at the cause for reducing the doses and consequently reducing the efficacy of the drug, it is the back of the mind thought that my patient will bleed and I have no way to stop that bleeding. So that is why the need for an agent which has a reversal agent available was realized. That there might be situations where a patient may be taking a NOAC and he might be either requiring emergency surgery or an urgent procedure, for example, a vehicular accident with a fracture, or he might require urgent cardiac surgery, a life-threatening ischemic episode, or a valvular disease or some such thing, or he might require neurosurgery, or he might have an acute abdomen. So these are the situations where you cannot wait, and you will have to have some effective agent, if possible, to reverse the effect of NOAC so that timely intervention can be done. So in a patient who is experiencing life-threatening bleeding, for example, intracranial bleed, or a critical organ or a closed space bleed, like inside the retina, or retroperitoneal or pericardial, or an ongoing bleed, which is happening, which is not responding to your standard measures. So this is the place where a reversal agent would be welcome. And that is why we now come to this newer era where we began. For 50 years, we had nothing but warfarin. Then we came to the novel or the oral anticoagulants. We start the journey began with dabigatran. Then the second drug was rivaroxaban. And finally, third one was apixaban. Edoxaban, of course, is not available in India. And then we come to an era, which is not a perfect era, but these are era with NOACs with a reversal agent available. And currently in India, we have only dabigatran, which has a specific reversal agent in the name of idarucizumab. It's called Praxbind, and which is the first and only NOAC with a specific reversal agent. So let us see whether this advantage is really an advantage to a clinician or not. Now, the clinician asks himself, why do I need newer drugs? I have been, for stopping the bleeding, I have been managing oral anticoagulation bleeding from ages. What I used to do is, I can stop the VK, I can give injection vitamin K, blood transfusions, FFP, PCC, and activated factor 7. So why should I need a newer reversal agent? So question is, will this work with NOACs? So let's see why it may not work with NOACs. It certainly does not work with NOACs. Now this is a bit of a surprise. So how do VKAs work? VKA works at multiple levels. So you can see warfarin has multi-level action. So it is a more potent anticoagulant, but it acts at multiple levels. And this is where, if you look at these are the agents where the reversal agents work. So you can reverse the agent of, you create more prothrombin by giving vitamin K. And you can give, supplemental factors. You can give blood transfusions, flush frozen plasma. How do these work? They basically supply the coagulation factors. And that is why the warfarin works by interfering with the production of vitamin K dependent factors. While and they cause depletion. So warfarin causes depletion of vitamin K dependent coagulation factors. And that is why it is rational to use vitamin K and the depleted factors, either combined or specifically like activated protein C or activated factor 7. So that is why these agents work in warfarin related bleeding. However, the NOACs have a different way of action. They interfere with the active principle of the coagulation. They do not deplete the procoagulant proteins. So if you look at the levels of fibrinogen and other prothrombin and all that, they will be normal. And that is why you realize that when you do a prothrombin time in a patient on NOAC, it will be normal because that prothrombin level is normal. While in a VKA, it has been depleted. So basically, NOACs will not respond to supplementing factors because the factors are already there. They block the action of specific activated factors. And that is why replenishing factors will not reverse the NOAC action. And that is why we have come to the idea of specific reversal agents for NOACs. So this was an observation from the American Society of Hematology, that the ability to turn the anticoagulation effect on and off as required will provide further benefit for patients, and it will give further confidence to the clinician who is using these drugs that no, I have a backup available in case my patient needs reversal. I have something that will lead to better utilization of these very good drugs, that is NOACs. So let's talk of this specific agent which is available to us in India. So basically this is a monoclonal mouse antibody. So it's a mAb, as the name suggests, idarucizumab. So it's a mAb which has been directed at a particular region of dabigatran which binds to dabigatran, and that is the Fab region. The FC region has been removed. So it's a very small molecule. It's a humanized Fab fragment expressed directly in hamster cells and produced in-house by Boehringer Ingelheim. So it's a small monoclonal antibody developed to direct its action only to dabigatran, and it has a specific dabigatran binding action which is 350 times more than dabigatran has affinity for thrombin. So how dabigatran acts? It goes and sits on the activated thrombin and does not allow the thrombin to act. So what idarucizumab does is occupies the same site which is occupied by thrombin. So dabigatran and idarucizumab forms a complex which does not have any anticoagulant activity, and it stops the action of dabigatran completely. So it is a specific binding to that particular region of dabigatran which has a very, very high affinity as compared to thrombin. So dabigatran would rather combine with idarucizumab rather than combine with thrombin, and that is how the action, anti-thrombin action of dabigatran is reversed. And this drug has no intrinsic procoagulant activity. So if you by mistake give it to somebody, it will not cause thrombosis. It has no other targets other than dabigatran. So it will not work if dabigatran is not present. So it's a very safe drug, specifically directed at dabigatran, and it has no procoagulant effect, unlike your factor supplementation like PCC and activated factor 7, which can cause widespread thrombosis if it is used indiscreetly. And this binding is very fast and it's irreversible. So once bound, that dabigatran cannot separate from idarucizumab and it cannot have action. So that is why it is theoretically one of the best possible drugs which you can have. So do we have any evidence for idarucizumab? Yes. The trial was called the Reverse AD trial, which had an objective to demonstrate the extent of reversal of anticoagulant effect of dabigatran in 2 subsets of patients. There were some 500 odd patients. Now this number is less because fortunately dabigatran does not cause too much of bleeding. And that is why the sample size we are used to sample size of thousands, like 16,000, 15,000, 18,000, while we have only 503 patients here. And what were these patients? They were basically a multi-center open label single arm phase 3 trial. And there were 2 types of patients. Group A was uncontrolled bleeding because of any reason. And group B was emergency surgery or procedure, who arrived to the hospital, who were on dabigatran and who required emergency surgery. So there had to be a reversal of the anticoagulant effect. They were not actually bleeding, but group A was bleeding. And group B was requiring an emergency intervention which could have led to bleeding. So what was given? 2 doses of 2.5 grams intravenously of idarucizumab within 15 minutes of each dose. So between vials, the interval was generally around 10 minutes. And then there were some primary endpoints. They looked at maximum reversal within 4 hours. Now there is a specific clotting test available, which is not available to us, but as research purpose it is available. It's called the Ikarin clotting time. And these were measured. And of course, secondary endpoints where the clinician decided whether there were any thrombotic events, whether there is any mortality, because and grossly whether the APTT became normal, drug levels, immunogenicity. The surgeon decided whether he was happy with the hemostasis which he saw on the table, So there were a lot of these clinical secondary endpoints which were important to the clinician. And so we had about 301 patients in the group A where we had uncontrolled bleeding, and about 200 patients in the emergency procedure patients. And what was found, these are the types of bleeding which were there: subdural, intracranial bleeds, gastrointestinal bleeds, intramuscular, retroperitoneal, etc. These were the group A patients who had major bleeding events. And these are the group B patients. Most of them were acute abdominals, which is a common presentation in our clinical practice. Fractures was another common thing, cardiovascular bleeding, and then there were a few rare types. And what was found? What was the evidence that they found? So one thing is they looked at the specific clotting test, and they found that when the patient came in, this is the group A uncontrolled, they had a very high clotting time, and within few minutes, the clotting time became normal. And this was seen in both the groups of patients. So this was a laboratory evidence. And dabigatran levels were also estimated, and they fell immediately. So this is active dabigatran, levels fell immediately. And the maximum time in group A, those who were bleeding, was 2.5 hours. And in those who had emergency surgery, the parameters became normal within 1.5 hours. So this was a very fast acting drug, which was very effective. So the key results here was that 5 grams of idarucizumab resulted in immediate, complete and sustained reversal of dabigatran anticoagulation. There was no repeat dose. The median time was 2.5 in bleeding patients, 2.5 hours, and in surgery patients 1.5 hours. And there were no safety concerns noted. Means there were no adverse effects like thrombosis or allergic effects or anything. So, and this was the idarucizumab in real world. It was called the ReVecto surveillance program. So apart from the controlled trial, we had this ReVecto surveillance program also gave us quite a good results. So now I can illustrate this efficacy in a couple of cases which were done in real world. And these are Indian case reports. In fact, one of them was from Bombay. So basically, this was a case published in IHJ. It was a fall with intracranial hemorrhage. Patient was on Pradaxa, that is dabigatran 110 milligrams BD. CT scan showed hematoma and sphenoid fracture. So a 79-year-old lady who had a fall and fall-related ICH, nasal bleed, unconscious, and speech impairment. And the CT scan showed hematoma and sphenoid fracture. Surgery was planned. The APTT was 71. Now, what they say is that though APTT is not a good measure, but at the trough level, that is after 10 or 12 hours of dabigatran, if your APTT is above 70, it means there is a lot of anticoagulant activity going on. So that is why this is a rough measure of anticoagulant. So by this measure, the patient was still in anticoagulant state. 5 grams of Praxpine was administered. Within 48 hours, the speech improved. There was no increase in hematoma. Day 8, surgery was avoided. Day 8, because there was no active bleeding. Day 8, low molecular weight heparin was restarted. 2 months, CT scan, no hematoma. And Pradaxa was restarted because this was a reversible cause of bleeding. And this was in Bombay. So we have a good evidence in terms of an actual case that you could reverse the effect, avoid surgery, and after some time you could restart anticoagulation because this patient had non-valvular AF and needed anticoagulation. So this is one kind of a case. The second is a stroke case, again in Mumbai. A young patient had a stroke and presented within 30 minutes of symptom onset. So well within the period of thrombolysis and or thrombectomy. And she was also on 110 milligrams BD. The NIHS score was pretty high, so it was probably a large stroke, and right upper hemiplegia. Praxpine was administered within 1 hour of admission. Then patient could be thrombolyzed because the APTT settled within 3 hours. The symptoms within 3 hours of symptom onset. Day 2, power in limb was normal. Day 14, patient was discharged and restarted on Pradaxa. So we have overcome a difficult problem where you have a bleeding in a patient requiring anticoagulation. You could immediately reverse the anticoagulant effect, administer proper therapy, thrombolysis. So this is a therapy which could be done even in a small hospital. And the patient could recover very well and could be restarted within a few days on that. And remember, this patient took 14 days to be restarted because she had a high NIHS score. So we have that 3, 6, 12, 15 rule where if you have just a TIA, you can start the next day, or depending on the severity of stroke, 3 days, 6 days, 9 days, or 12 days. So this patient, because he had a high NIHS score, they waited for 2 weeks and then restarted. So this is another day-to-day situation. Now we have another agent which is though not available in India, but we should know about it. It's Antaxenate alpha, and this is a drug which is used for reversing the effects of 10A antagonists, that is rivaroxaban, apixaban, and edoxaban. But this drug, unfortunately, requires to be given continuously as an infusion. Etanercept, there are just 2 doses given within 10 minutes. While Antaxenate alpha, it's not available is one thing, but the effect lasts only as long as you continue the infusion. So if your rivaroxaban or if your apixaban half-life is say 2 days, then you may have to continue giving the Antaxenate alpha infusion for 1 or 2 days. And it's not easily available. It's very difficult to continuously give. So between the two, etanercept is a better drug. So the message that I would like to give, that though I don't specifically prefer any NOAC, but if you have a situation where you might anticipate that this patient will require reversal of anticoagulation in the near future, then probably your choice of drug should be dabigatran, unless there is some specific contraindication like the renal failure is evident where you cannot use dabigatran. So as of now, for a clinician, if he decides to use a drug with a reversal agent available, he is probably much more confident. He will use proper doses of the anticoagulant because now his fear of bleeding is gone. And if there is a problem, then he can immediately reverse this. This drug is available, supplied throughout by Boehringer Ingelheim. If you are on the original drug, it is given free. And so it has been tested against some of the generics also. It works there also. And they have an India-wide network. So within 1 hour, they are able to supply the drug. Thank you very much.
Hi. Ronak, are there questions? Can I ask one?
Yes, sir. Definitely you can ask. Sir, there are no questions from the audience.
I see in your case number 2, your patient was on Pradaxa 110, and
Yes.
your patient, I mean the patient,
yeah.
was on Pradaxa 110 and developed thromboembolic stroke. And of course, you reversed it and thrombolized. And you said that after 14 days, you again went back onto the same drug. So would you have increased?
Yeah. So that actually emphasizes my point, that one should not use, this is a young patient with no background, nothing, no renal failure, nothing. So the choice of 110 milligrams was wrong. And probably the decision to restart was 110 was also wrong. So that part I agree with you. So it definitely illustrates why was this young patient put on 110? Because at the back of the mind, the clinician was scared of bleeding. He forgot that here right now his patient has never bled. His idea to start anticoagulation was to prevent strokes. But he defeated it by starting a lower dose. So that is exactly the point that I have to bring in, that if you have this confidence that I have something to reverse the agent available, I will use proper dose. So your observation is correct. 110 milligrams to begin with was wrong, and to restart was also.
Right. One more point. I have had a patient who was on rivaroxaban 15 milligram for atrial fibrillation, 79-year-old lady. She was quite well built, tall, maybe almost 5'8" and measuring, weighing 80 kgs, otherwise fully fit lady. And she was on a full dose rivaroxaban for atrial fibrillation, and one fine day developed a huge intracranial bleed. Huge means it was something to see. A CT scan showed a huge bleed with compression and all that. And we had to decompress her by doing a craniotomy. And we used factor 7 activated NOVA 7 or something is the
it's NOVA
7 was the name, and I think it cost some nearly, I think
it costs around
1.5 lakhs.
yeah, so 40,000 per dose, so it's about 80,000 rupees.
Yeah, so,
2 doses you have to give.
So yeah, I think they gave more or whatever. So it was more than 1.5 lakhs for that, but it did work. The patient underwent a successful craniotomy and decompression within say I think 1.5 hours of giving of admission rather. Fortunately, at Lilavati we had that NOVA 7 available, and the patient was well affording. We could give it within 30 minutes or so, and in 1.5 hours the patient was operated with a craniotomy. Patient did beautifully well, no neurodeficit, and in 3-4 days was back to normal, of course. So this is my observation, that can you, for the other drugs, not available, that is true, but it's just an anecdotal experience of mine?
No, it may be true, because the reason is it's not the NOVA 7 which worked. I'm sure this patient probably had the last dose of anticoagulation 24 hours before.
She had it in the previous evening, and this so she had the dose by around 7 o'clock or so in the evening, and she got the stroke at around 7 in the morning. And
so the rivaroxaban was already at trough level.
Maybe, yes.
Yeah, so that's one of the factors. Now, if you have a minor bleeding, for example, and then you want to decide whether you want to give a reversal agent or not. The recommendation is, if it is 12 hours from the dose, there is no need. Minor bleed which you can compress and take care, then that is the reason why probably this patient had already started showing less anticoagulant activity. Theoretically speaking, NOVA 7 should not work. Should not. It worked. I don't know why it worked. Probably the anticoagulation was already down, and she was on 15 milligrams, right?
Yes. She was on 15
so that was anyway a lower dose.
Yeah.
And she was a good sized patient, probably with normal renal function.
That's what I told you.
And that is why I think the 15 milligram dose was at present inadequate, and she was already at the trough level.
But
and
with that 15 milligrams, she had a huge bleed.
Yeah, but we don't know when the bleed happened. The bleed might have happened slowly.
No. Yeah, okay, fine.
At the peak of anticoagulation action. Yeah, see, we say all these things. We ultimately land up giving FCC, fresh frozen plasma, blood, etc. We do give that. Theoretically, it is not expected to work. But we can't just sit back and do the thing, which is a scary situation.
Okay, so there are 2 questions. One is from Dr. Ankur Rawal.
Yeah.
Any side effect of NOACS, concern and solutions? I think we have already discussed hemorrhagic side effects. Any particular non-hemorrhagic side effects you have noticed with NOACS?
Yeah, dabigatran works through the PG2 pathway in the intestine. So it is one drug which leads to maximum GI intolerance, not bleeding, but very, very, very. Some of the patients just cannot tolerate it. They will rather stop the drug than take it. So one of the other problems is GI intolerance, specifically with dabigatran. It's not with the other 2. GI bleeding is much more with rivaroxaban, but GI intolerance is maximum with dabigatran. And second thing is, if you have drugs like verapamil, diltiazem, or even amiodarone, then the dabigatran reabsorption is interfered with. So other excretion is interfered with, because dabigatran also gets excreted through the intestines, and this pathway is inhibited by these drugs. So you can have increased levels of dabigatran if you're on these drugs. So this is one drug-drug interaction which is a problem. Some of the ketoconozoles, the antifungals, also interfere with dabigatran. So because it's basically some of it is activated in the liver. So there is some, though it's just 15%, but some interference with the levels of dabigatran do occur. So these are some of the, not side effects, but some of the cautions which you have to take care.
Okay. There is one more question from Dr. Rajanya Patel. Can we measure NOACS effect with conventional PT or APTT?
No, APTT works in a very rough manner with dabigatran because it acts on the thrombin, and APTT ultimately targets thrombin. So if you have the only way you can use this is that at 12 hours, that is the trough level of dabigatran, if your APTT is 70 seconds or more, the effect is still there. If it is less, it means the effect is less, but there is no linear correlation. You can't say that because the APTT is 100, it is more, or if it is 35, it is less. That kind of correlation doesn't exist. But this is a rough observation. If a patient comes to you with bleeding, in a patient who has taken dabigatran, say 12 hours before, and if his APTT is below 70, you are sure that the effect is wearing off. And then you can, kind of grossly correlate it that way. But there are no specific tests. We used to do, I was part of Relay trial. We had done APTT and PTTs on these patients, just like that. It was not part of the trial. And we did find that they were disturbed in some patients, but we could not actually correlate with the anticoagulant effect. So no, we cannot use the standard anticoagulation measures in these people.
Okay. So thank you, sir. I think there are no more questions on this topic.
Okay.
Thank you, sir, for the very informative lecture. I would like to request Dr. Sagar to enlighten us on the resistant hypertension. Dr. Sagar, over to you.
Good evening, everyone. I think it's already the time has exceeded. So what I and Dr. Ronak will do is just touch upon a few important slides instead of the whole presentation. I think it's
the most important slide.
Yeah. Yeah. So the concept of hypertension, it started initially people thought that it was just a compensatory mechanism and it was not pathological. Someone even said that the greatest danger to a man lies in the discovery, because then some fool will try to reduce it. So initially people thought that it was just some compensatory mechanism. Now we all know the incidence of hypertension is increasing. It is more in the urban areas as compared to the rural areas. All of us are familiar with the rule of halves, that only half are being diagnosed and half of those diagnosed are treated and half of those treated are adequately controlled. So there is 12.5 overall incidence of inadequate hypertension. So why hypertension is important? Because it is responsible for 35% of all cardiovascular deaths, 50% of stroke deaths, 25% of CAD deaths, 50% of CCF, and 25% of all premature deaths. Now, there is an important concept which has come, the automated office BP measurement, instead of routine auscultatory office BP measurement. In this, what it is done is that patient has to sit alone quietly in the examination room for 5 minutes. Oscillometric monitor takes 5 readings, 1 minute apart. So based on the average reading, we can diagnose hypertension. So if the average is more than 135/85 or higher, and the patient has ECG confirmed LVH or hypertension induced target organ damage or severe blood pressure more than 180/110, then we diagnose hypertension. So basically, diagnosing hypertension, the level is just arbitrary level, and if there is some target organ damage, then it proves that the patient is having the higher blood pressure is pathological in that patient. And in the absence of target organ damage, what we can do is we can check ambulatory blood pressure or home BP monitoring to confirm the diagnosis. Now the advantage of automated office BP monitoring is that it minimizes white coat reaction, it correlates better with home or awake BP, and it eliminates digit preference. Hypertension can have various target organ damage, which includes the kidney, the heart, and the brain, and the peripheral vessels. So ambulatory blood pressure monitoring, it's the gold standard for diagnosing hypertension. The cutoff values is For daytime, more than 135 systolic, more than 85 for diastolic. Nighttime, more than 120 systolic and more than 70 diastolic, or 24-hour average, more than 130 systolic and diastolic more than 80. So recently, every year we can see that new guidelines are coming. AHA released its guidelines in 2017, then ESC in 2018, NICE guidelines in 2019, and recently International Society Hypertension guidelines in 2020. So there are a lot of guidelines coming which are used to denote what is normal BP and what is hypertension. So normal, AHA defined normal as less than 120 systolic and less than 80 diastolic, and elevated 120 to 130 and diastolic less than 80, and then stage 1 and stage 2, so on. ESC has used a higher limit of for defining abnormal BP. Grade 1 is 140 to 160 as compared with AHA guidelines. We will not go in detail regarding this. My presentation was basically based on this article from November 2018, resistant hypertension. Prevalence is approximately 10%. Now, defining resistant hypertension, if it remains persistently above the goal, despite concurrent use of 3 different drugs, mainly calcium channel blockers, ACE inhibitors, or diuretics, all agents administered at maximal doses, white coat effect has been ruled out and adherence to therapy has been checked. So if all these points are matching, then only we can say that patient is having resistant hypertension. Also, if BP is controlled with more than 4 antihypertensive medications, then it is called as controlled resistant hypertension. So uncontrolled hypertension and resistant hypertension are not the same. The purpose of defining this group, it is not to count the number of drugs required, but to identify a particular subset of patients. These patients are more likely to have adverse effects. They are likely to have a secondary cause of hypertension, and they may benefit from a specific diagnostic or therapeutic approach. So on the basis of number of drugs, it is called as either uncontrolled, resistant, or refractory. If more than 5 drugs are required, it is usually called as refractory hypertension. Pseudo-resistant, resistant, and refractory, it is like the good, bad, and the ugly. Resistant and refractory, these are 2 different subsets. Resistant hypertension is usually volume dependent, whereas refractory is more likely neurogenic in nature due to sympathetic overactivity. Now, what is pseudo-resistant hypertension? Pseudo-resistance means there is overestimation of blood pressure. Either it is due to wrong technique, wrong prescription, or abnormal patient behavior. So it includes improper blood pressure measurement techniques, heavily calcified arteries, white coat effect, poor patient adherence, inadequate dosing, inappropriate combination, or physician inertia to increase the dose or change the regimen. Now, errors in BP, it depends upon the cuff size, the technique of BP measurement. We will not discuss this. We will BP. Non-adherence is there in at least 50 to 80% of hypertensive patients. The reasons being large pill burden, dosing complexity, the high expense, high frequency of adverse reactions, poor patient-clinician relationship. Prognosis, 32% of these patients are at high risk of developing end-stage renal disease, 24% at risk of ischemic heart event, 46% at risk of heart failure, 14% risk of stroke, and 6% increased risk of death. It has been found that the risk of stroke, CAD, or heart failure decreases by 13% patients with resistant, whereas 31% in without resistant. So this is a particular subset where even after treatment with adequate antihypertensive, the benefit is not so much. These people are usually from of black race, older age, male sex. They have non-dipping or reverse dipping BP, sympathetic overactivity, visceral obesity, and they have excess aldosterone levels. So these and they usually have obesity, LVH, albuminuria, diabetes, CKD, obstructive sleep apnea. So this is a particular subset where resistant hypertension is more prevalent. Wrong prescription patterns. is usually responsible for pseudo-resistant hypertension. It includes inadequate doses, absent chlorthalidone or spironolactone in prescription, and no bedtime drug. Now, importance of bedtime drug is that majority are non-dippers. By non-dippers, what I mean is usually physiologically the blood pressure should decrease at night time, which is not occurring in these patients. And even after giving a drug which is acting for 22, which is a long-acting drug, few have 24-hour control. That means the drugs which are given in morning, they are not effective at night. So it is very important to add a bedtime drug for a better 24-hour control. Various lifestyle factors are associated with resistant hypertension like obesity, increased dietary sodium, alcohol intake, physical inactivity, psychosocial stressors, reduced sleep quality and duration. Various drugs can interfere and cause elevated BP and hypertension like NSAIDs, oral contraceptives, sympathomimetic drugs, cyclosporin, erythropoietin, VEGF inhibitors, alcohol, cocaine, amphetamines, and antidepressants, glucocorticoids. All these interfere and cause hypertension. NSAIDs are usually the most common culprit, and NSAIDs decrease the efficacy of diuretics, ACE inhibitors, ARBs, and beta blockers. There is no effect of NSAIDs on calcium channel blockers and alpha blockers. Secondary hypertension should be ruled out. There is a long list of causes which can cause secondary hypertension, but we should suspect it in young hypertensive patients, first time hypertension after 60 years. Patient was well controlled or when controlled with 2 or 3 drugs, but now it is out of control. The most common causes of secondary hypertension are renal parenchymal disease, renovascular disease, primary aldosteronism, obstructive sleep apnea, and drugs or alcohol. So these are the most common causes of secondary hypertension. Lifestyle interventions, as I discussed, that we have to decrease physical activity has to be increased, alcohol has to be reduced, sodium intake has to be reduced. Evaluation of resistant hypertension. First, we should confirm treatment resistance. Clinically, BP should the pattern should be at least 3 drugs should be given in maximum tolerated doses. Pseudo resistance should be excluded. Assess for secondary hypertension. Rule out the causes of causes like primary aldosteronism, renal parenchymal disease, renal artery stenosis, pheochromocytoma, Cushing syndrome, obstructive sleep apnea, and coarctation should be excluded. Assess for target organ damage, like we should exclude hypertensive retinopathy, hypertensive nephropathy, peripheral arterial disease should be evaluated. Regarding management, step 1 includes, as we discussed, we should exclude other causes, a low sodium diet, a proper sleep, a proper dietary pattern, DASH diet and Mediterranean diet are favorable, weight loss and exercise. So non-pharmacological interventions are very important. Then we should optimize a 3-drug regimen, that is maximally tolerated doses of an ACE inhibitor or ARB, calcium channel blocker, and diuretic. Step 2 includes substitute optimally dosed thiazide like diuretic like chlorthalidone or indapamide. Step 3 includes mineralocorticoid receptor antagonists like spironolactone. Step 4, if the heart rate is heart rate is more than 70, we should add a beta blocker. Most likely labetalol, carvedilol, or nebivolol are preferred. Step 5 includes hydralazine. Step 6 includes minoxidil. Other regimens, there are also various other pathways by which we can treat resistant hypertension. Step 1 includes ACE inhibitor with calcium channel. Step 2, dual full dose combination of ACE inhibitor with calcium channel. Step 3 is triple combination of ACE inhibitor, calcium channel blocker, and diuretic. And step 4, we have to add spironolactone. One more approach to treat resistant hypertension is initially, hypertension is a response of the body to either volume expansion or to excess vasoconstriction. So the plasma renin level reveals the contribution of body sodium volume and renin-angiotensin constriction to long-term blood pressure. So basically, BP is the product of volume and resistance. So regardless of all etiology, all forms of hypertension comprise inappropriate sodium retention or excessive vasoconstriction. So sodium retention or excessive vasoconstriction is the final common pathway for increased blood pressure. So we have to concentrate on these two things, sodium retention, sodium levels and vasoconstriction. So the drugs which we give are either anti-V or anti-R. So low renin, we have to identify the pathology, whether the hypertension is due to volume retention or excessive vasoconstriction. So accordingly, there are two types of drugs: anti-V drugs, which include aldosterone antagonist, diuretic, calcium channel blocker, alpha blocker, or anti-R drugs like renin inhibitors, ACE inhibitors, ARBs, beta blockers, or alpha-2 agonists. So depending on the plasma renin level, we can determine which type of hypertension it is, low renin or normal renin or high renin, and then accordingly we can decide. We have to give the choice of diuretic is very important. Hydrochlorothiazide has no predictable natriuresis below a GFR of 45. Whereas chlorthalidone acts up to 30 ml per minute per 1.73 meter square. So chlorthalidone is better as compared to hydrochlorothiazide in patients with low GFR. And below this, long-acting diuretics like torsemide should be used over short time diuretics. Nighttime dose, as I already told, is very important. We should always try to reach at least the maximum dose of the antihypertensive which we use. Apart from this, two new concepts like renal denervation has come. However, we know that all the simplicity trials 1, 2, and 3 have failed to impress. But there is a subset of patients with a more complete ablation. The BP response was better. So, and some spiral and hypertension off meds study using a different catheter has provided better results. Carotid baroreceptor activation therapy also helps in reduction of blood pressure, and there are newer drugs which are coming up like alescarin, NEP inhibitors, eplerenone, aldosterone synthase inhibitors. So all these can be again tried. Thanks a lot.
So I think there is one question from Dr. Ankur Rawal. Arthamine and moximidine as medical denervation, expert comment from Dr. Bhavesh Vajifdar.
Sorry, I could not hear you well, Ronak. Can you please repeat?
The question from Dr. Ankur Rawal.
Yes.
Arthamine and moximidine as medical denervation, expert comment from you, sir.
Okay, so I think a few things about this resistant hypertension. So of course, the first thing is that you have to be on 3 drugs. You have to be on an ACE or ARB with a calcium channel blocker and a diuretic. That Sagar has beautifully told us a lot of details about hypertension and resistant hypertension. And the next drug to add, the 4th drug to add has to be a MRA. That is mineralocorticoid receptor antagonist. It could be a simple aldosterone or eplerenone. So I think these 4 drugs have to be on board before we really say that this patient has resistant hypertension. The other thing is that once you have no blood pressure control with all these drugs, then the chances that either it is pseudo resistance, that means the patient is not taking drugs or is taking too much of sodium or not taking the proper therapy are very high, or secondary hypertension are very high. So it is very, very unlikely that a person with primary or essential hypertension, or you can't call it essential hypertension, primary or idiopathic hypertension, if you give these 4 drugs, then it is going to be very rare that this person will not be well controlled. So that is point number 1. So once you are with these 4 drugs, and if the patient is not well controlled, you have to look at all these factors. The most important thing would be a 24-hour ambulatory blood pressure monitoring, because that will help us really tell whether this patient is getting a white coat effect or not. And that is number 1. Then number 2, of course, we need to interview him and his family for drug adherence and for salt restriction. And then we should investigate these patients for possible causes of secondary hypertension. The most common, of course, creatinine, USG with a renal Doppler, serum potassium levels to look at, and then renin also, as he has rightly said, Sagar has said. So these are some common things which cause. In a young patient, of course, coarctation and aortoarteritis should also be looked for, and simple examination of the peripheral pulses and radiofemoral dealers can tell you about this. So, very rare circumstance will come where you will need to go beyond that. Then you have the things like pheochromocytoma, where actually you won't have resistant hypertension. Most of the time there'll be a fluctuating labile hypertension, where sometimes patient is normotensive and then suddenly the patient becomes hypertensive. So you have a test like serum or plasma metanephrine level, which is a very simple test, easily available, no need for any fasting or anything. You can just do a stat test. Of course, it may not be available everywhere. The question about the drugs, which were the drugs which were asked by Ankur?
Clonidine, Arcamin.
Okay. So I think today in my practice, where I'm sure there may be not hundreds, but maybe in thousands patients following up with hypertension with me, I can count not more than 10 patients who will be on clonidine or Arcamin. And they are primarily because they have been the elderly people who have been on that. And I think in my practice, as far as possible, I'm not using clonidine or Arcamin. Even if the patient comes with that drug, I've had patients who have been labeled as resistant hypertension and hence were on these drugs. But after evaluating them and putting them onto a proper diuretic, as you rightly said, chlorthalidone plus MRA, that is aldactone, and the other drugs, beta blockers, alpha blockers, plus ACE inhibitors, and this, I think I could remove these patients from their Arcamin or clonidine. So I don't see the role of Arcamin or clonidine in the treatment for resistant hypertension, because the problem I have seen patients who miss one dose of that, and you can have a rebound hypertension, and that could be worse. In a patient who is already hypertensive or resistant hypertensive, if you miss the dose and if you have a rebound, it's going to be difficult.
Moreover, sir, these alpha-2 agonists, they have more complexity in dosing regimens. They have to be taken many times a day. There is rebound hypertension is there if the patient misses any doses. There is a lot of postural hypertension also associated. So I think these drugs have gone out of repute right now. And there is some recommendation like some dermal patches of this clonidine are available, which provide long-term effective drug levels, which can help.
I have not used them. I have never used that patch.
Okay, so there was one more question. What could be done in patients with hypertension who are having intermittent orthostatic hypotension episodes? Which drug could be safe in this scenario?
Patients who have hypertension but are getting orthostatic hypertension.
Yes.
Okay, so I think this is a really difficult situation where you have a patient who needs multiple antihypertensive drugs and at the same time is having orthostatic hypertension. Number one, you will have to probably look at the volumic status of the patient and see whether he is underhydrated. I think that would be one major thing, because if you have underhydrated or hypovolemic guy and if he's on, say, vasodilators plus diuretics, then that is going to be very difficult. So probably you would have to look into that. If the patient does not have, because most of these patients are elderly patients and they have significant systolic hypertension and not so much of diastolic hypertension, and hence many a times these patients are on diuretics. And these are the patients who are prone to getting orthostatic hypertension. Perhaps a judicious reduction in the diuretic therapy, a good postural advice, and an increase in the volume status if the patient is euvolemic would be the way forward. Perhaps beta blockers may be of some use. They would cause minimal orthostatic hypotension, and some of the vasodilators could be replaced by a beta blocker. Dr. Jhala, do you have anything to say in this?
Yeah, see, most of these people have hypertension when they are sleeping. That's obviously orthostasis. Means in the daytime, they are not hypertensive. And in fact, they are on the lower side. So what is recommended is that they should be given a nighttime dose of a short-acting drug, which could be a short-acting ACE inhibitor or a beta blocker. And in the morning, they should be supported by supportive stockings. So this is a very odd. Occasionally, we have even used daytime vasoconstrictors like midodrine, which is a very short-acting drug, which takes care of their morning hypotension. And by the time they are sleeping, the effect wears off, and then they can given a small dose of beta blocker or an ACE inhibitor or an ARB, but definitely no calcium channel blockers, no diuretics, and no alpha blockers. So I think this is a very difficult situation where it's the opposite, but this is the best way to manage them. Short-acting drugs at night and plus minus vasoconstrictors in the morning. Occasionally, fludrocortisone also works in them in the morning, which has an effect of around 10-12 hours. So you will have to combine these drugs, mutually oppositely acting drugs.
Okay, so thank you, Dr. Sagar. Now we'll move ahead to the last session of the day, that is on dyslipidemia. I'll not take much, but maybe 5 to 10 minutes. So how to approach to patient with dyslipidemia? I'm not going into any worldwide data or any further details, but this was the 2019 ESC guidelines, which is the recent guidelines as per our knowledge in dyslipidemia. So the step one, whenever any patient comes to you, first step is to go for risk assessment. Now there are many risk assessment scores are available, but these guidelines had been introduced to a scoring system, which is a scoring system, which can be found on heartscore.org. And the parameters involved in this is age, gender, systolic blood pressure, total cholesterol level, HDL cholesterol level, and history of smoking. So the interesting fact here is on this data, which was originally created for high risk as well as low risk region of the Europe. Now, if we compare the Indian data or Indian population, they are as near as high risk region of the Europe. So we will consider only high risk region of the Europe. And this score system analysis will give us 10-year risk of fatal cardiovascular disease. So this is the data for female and this is the data for male. So first, if we take a male who is non-smoker and aged of 60-62 years, somewhere between 60 to 65 years, and non-smoker and systolic BP of 120, total cholesterol of 4. They have given in 4 millimole per liter. So the risk factor here is 4. So 4 means the risk is 3 to 4% over a period of 10 years to having a fatal cardiovascular disease. And if we compare this with this gentleman who is age 40 years but smoker with systolic BP of 180, cholesterol level remains same in both. The only difference here is age, smoking, and systolic blood pressure. The risk factor here, in spite of being younger counterpart, the risk is same. So age, smoking, as well as systolic blood pressure plays a vital role in the risk assessment ratio. So then second step comes as the categorization of the patient. The patient can be categorized in various categories like very high risk group, low risk group, and moderate risk group. Very high risk group is a patient who has documented atherosclerotic cardiovascular disease. It can be documented either clinically or it can be documented on the imaging. Imaging means CT scan scoring, CT or calcium scoring or CT coronary angiography. Then diabetes with target organ damage or early onset of type 1 diabetes with long duration of more than 20 years is again very high risk group. Severe CKD means EGFR of less than 30 is very high risk group. Familial hypercholesterolemia with atherosclerotic cardiovascular disease or another major risk factor of any of the above is considered as very high risk group. And this calculated score that we discussed in last slide of more than 10% for 10-year risk is also considered as very high risk group. And then there are shown high risk group, moderate risk group, and low risk group. Why it is important to know this? Because the treatment parameters or the target value of LDL, HDL, and total cholesterol differ according to the various categories. Now, the treatment target which was given in this guidelines for very high risk group, there should be at least more than 50% reduction from the baseline in LDL cholesterol, and LDL cholesterol absolute target should be less than 55. For high risk group, again the target is same, more than 50% reduction, and absolute LDL cholesterol should be less than 70. Moderate risk group, LDL cholesterol should be less than 100. And for low risk group, LDL cholesterol should be less than 116. Other parameter targets, BP should be controlled to less than 140/90 millimeter of mercury. HbA1c should be controlled to less than 7%. Non-HDL cholesterol total should be less than 85 in very high risk, less than 100 in high risk, and moderate risk group it should be less than 130. Triglycerides as such, there was no goal was given in this guidelines, but less than 150 should be indicated in all risk group patients. Now, if we compare this with our Indian data, so this was the Indian data guidelines given by Lipid Association of India in 2016. Indian guidelines was more or less similar. Less than 50 should be targeted in very high risk group, although their high risk group and very high risk group were slightly different. The high risk group target was less than 70, moderate risk group target was less than 100, and low risk group again less than 100. So more or less Indian counterpart, the target should be also more or less similar. If we consider a particular subset like atherosclerotic cardiovascular disease patient who experience a second vascular event in terms of myocardial infarction or stroke within 2 years of the previous event, the criteria or target is further stringent, that should be less than 40 milligram per deciliter of LDL cholesterol goal. The treatment strategy, yes, always treatment strategy starts with the non-pharmacological measures. Non-pharmacological measures includes no exposure to tobacco in any form, healthy diet which is low in saturated fat with a focus on whole grain products, vegetables, fruit and fish, 3.5 to 7 hours of moderate vigorous physical activity per week, or 30 to 60 minutes of moderate vigorous activity all the days. BMI should be controlled to 20 to 25 kilogram per meter square, and weight circumference should be reduced to less than 94 in case of male and less than 80 in case of females. And certain guidelines also administer moderate amount of alcohol. They recommend moderate amount of alcohol intake for control of dyslipidemia, particularly for control of hypertriglyceridemias. And moderate amount of alcohol means 1 drink per day for women and 2 drinks per day for men. 1 drink includes 12 ounces, that is a 360 ml of beer, 150 ml of wine, or 45 ml of distilled spirit, that is whiskey or vodka. Treatment strategy in pharmacological, the major stress in this all recent guidelines is given on high intensity statins. So whether we consider LDL lowering, HDL increasing, or triglyceride lowering, first and all the drugs includes high intensity statins. So if we look at the guidelines, the recommended guideline says high intensity statin up to the highest tolerated dose should be the class 1 indication. If the desired lipid levels cannot be attained with high intensity statins, then ezetimibe could be added. And if this combination, high intensity statin and ezetimibe, cannot control LDL, or we cannot reach up to the desired LDL goal, a PCSK9 inhibitor may be considered, but this is still class 2B recommendation. Class 1 recommendation is always high intensity statin and ezetimibe. So how this statin, ezetimibe, and PCSK9 inhibitors are effective. A moderate intensity statin could averagely lower LDL cholesterol level by 30%. If we go to high intensity statin, it reduces LDL cholesterol up to 50%, which should be our desired target. And if it is not controlled, a high intensity statin plus ezetimibe should ideally lower LDL cholesterol to 65%. If we take PCSK9 inhibitor alone PCSK9 inhibitor can reduce LDL cholesterol up to 60%, but which is not yet a class 1 recommendation. PCSK9 inhibitor plus high intensity statin can reduce it up to 75%, and all three combination, PCSK9 inhibitor, high intensity statin plus ezetimibe, it can reduce the LDL cholesterol by 85%. But unfortunately, we don't have any PCSK9 inhibitor available commercially as of now. For hypertriglyceridemia, in short, this is old guidelines, which is ATP3 classification. The triglyceride level of 150 to 200 is considered as a borderline high. 200 to 500 is considered as a high, and more than 500 is considered as a very high. So what guidelines says, statin treatment is recommended as a first drug of choice to reducing triglyceride levels below when it is more than 200 milligram per deciliter. And if it is not controlled, or if triglyceride is beyond 500, then addition of omega-3 PUFA should be done, that is eicosapentail ethanoic acid. And how nutrition and triglyceride lowering drug affects on triglyceride level. A weight loss of 5 to 10% of body weight will reduce your triglyceride by 20%. Implement a Mediterranean style diet will reduce triglyceride by 15%. Omega-3 fatty acid addition into diet will reduce it by 10%. Carbohydrate reduction in diet by 1%, or energy replacement with omega fatty acid reduce triglyceride by 2%, and further on. So mainly the role of diet comes in reducing triglycerides. So for hypertriglyceridemia, diet as well as drugs will be effective. How drugs will affect? Statin will reduce your triglyceride level by 10 to 37. This is absolute value. Omega-3 fatty acid will reduce by 19 to 44. Fenofibric acid, gemfibrozil, niacin. But this many trials we have seen by now that fenofibrate, niacins are not useful in terms of improving cardiovascular mortality or MACE rates. Now, in particular subset like acute cardiac syndromes, ACS type of scenario, first and foremost drug is high dose statin as early as possible, regardless of the initial LDL levels. And lipid level should be reevaluated after 4 to 6 weeks after ACS to determine whether the target of 50% reduction from the baseline is achieved or not. And then we can further go ahead to our absolute targets. If the target is not achieved, first drug to be added is ezetimibe. Second drug which could be added is PCSK9 inhibitors. Now there are many frequently asked questions in this scenario which I will cover. The lipid level should be done fasting or non-fasting. The traditional recommendation is fasting lipid level, but recent study has demonstrated that there are no difference between fasting as well as non-fasting measurement of lipid levels. So for general risk screening, non-fasting samples are adequate. How often lipids should be tested before starting therapy? At least 2 measurements should be tested in non-SES patients, non-asymptomatic patients. At least 2 measurements with interval of 1 to 12 weeks. So nearly around 3 months apart, 2 measurement has to be taken. Exception here is conditions where prompt drug treatment is required, like ACS or very high risk group of patients. How often lipids should be tested after starting the therapy? After starting therapy, the first recheck should be done somewhere between 2 to 3 months. And after any adjustment of treatment, every 2 to 3 months, a patient's lipid level should be checked. And once goal is achieved, the lipid level should be checked further annually. And these are SGOT, SGPT, and CKMB, which I will not go in detail. So this was more or less in short summary on dyslipidemia management, current guidelines in 2019 and 2020. Any questions on this?
Ronak, very nicely summarized. Of course, it's a very vast topic, but you tried to do this, and I think
we can discuss in detail in CardCon.
I think it was a good job you did. I just only want to add that PCSK9 inhibitors are very much available in India, freely available. The trade name here, it's evolocumab is the molecule and which is available here. And the trade name is Repatha by Dr. Reddy's. And the dosage is 140 milligrams subcute injectable twice a month, means every 2 weeks. And the cost is, though the label price is I think around 19,000, but the cost comes to around 14,000 to most of the patients per dose. So it's easily available here. And sometimes we do use it. Of course, it's not very common to use it.
Okay. I think there is one question from Dr. Ankur Rawal. Can we safely replace lipid profile with non-HDL cholesterol? Can we decrease dose of statin if HSCRP is normal? Any views on this, sir?
Okay. Shall I? Okay. So number one, non-fasting lipid levels are being evaluated, and though they are not into the guidelines, but you can definitely look at non-fasting levels, and non-HDL levels could be the thing which we are looking at. That is number one. But I think it is still some time before it comes into the guidelines and when we get the exact values which we could be looking at. Second, what was the second question?
Can we decrease dose of statin if HSCRP, high sensitivity CRP, is normal?
I don't think HSCRP has any role to decide the intensity or dosage of statin therapy. Dr. Jhala, will you want to answer any of these two questions?
Yeah. HSCRP is good for starting lipids, anti-lipid therapy. One of the trials, Jupiter trial, that is the one that took into account the levels of HSCRP. But there are no recommendations that you reduce statins once the HSCRP comes down. So that basically reduction in statin therapy is generally not done. And I think we should now come out of this thinking that once the lipids are normal, I will reduce my therapy. No, that's not true. Because this therapy is effective as long as you continue it. And if you are needing high intensity statins, you better continue high intensity statins. No other parameters other than, so by and large, 95% of your patients will never require any reduction. Because the PCSK9 trials have shown that up to 30 or about 15 milligrams percent of LDL is also okay. In fact, some people have gone to the extent that 0 is also okay. So there is no reason to reduce. There is no point in panicking. If your patient is tolerating statins, which most of them will do, there is no reason to reduce statins. So regardless of HSCRP levels, it should not be reduced. And the second one, the first one was
fasting cholesterol versus the non-fasting lipid profiles.
No, it was something else. I think it was something different.
The question was whether we can use non-fasting samples and whether non-HDL.
No, non-HDL. Whether a non-HDL should be used as a target.
Yeah.
Well, the thing is
the
that
question was about fasting, I thought.
No, it was about non-HDL cholesterol.
We replace lipid profile with non-HDL cholesterol.
Non-HDL cholesterol. The thing is that the question is good because if you have achieved an LDL target, but if your non-HDL is still high, you still have to intensify. Because LDL cholesterol is only estimating LDL cholesterol. The other cholesterol carriers, which are triglyceride-rich lipoproteins, are not being estimated, and they also add to the risk factor. So you have to meet both the targets, the LDL as well as the HDL. So if the non-HDL is not reached, you have to intensify the treatment. So don't stop at if you have reached 55, but if your non-HDL is still high, then you still have to intensify. So it can't be replaced, but yes, it's a good indicator.
Right. Sorry, I had answered as if you had asked whether there was fasting versus non-fasting.
And there was one continuation to this question. What is incidence of new onset diabetes for patient on statin?
It's very low, and that new onset diabetes is probably chemical diabetes with no clinical consequences. So it has been hyped out of proportion. The benefits of statin outweigh the benefits of the loss because of a little rise in sugar.
I think there are no more questions. So, yeah, should we end up the session here? I think.
All right.
Over to you, Mr. Bhavesh. Bhavesh.
Yes, we can do that.
Yeah.
So I think personally, I would like to thank Dr. Banker and Ronak and the entire team here for such a nice interactive session of learning for all of us. I learned a lot from Ashish and from Dr. Jhala, who was really stayed with us for the whole session and guided us through this. And of course, from Sagar and Ronak from you also. So we learned quite a few things, good revision for us. I think it was good. Thank you.
Okay, so thank you all the speakers as well as all the participants for sparing this time on this Saturday evening. Thank you very much, everyone.
Thank you.
Thank you.